AVPR2, an X-linked condition that usually presents in young boys. Diabetes insipidus from ADH deficiency is designated as central to differentiate it from nephrogenic diabetes insipidus, which is a result of renal tubular unresponsiveness to circulating ADH. The clinical manifestations of these two disorders are similar and include the excretion of large volumes of dilute urine with a lower than normal specific gravity. Serum sodium and osmolality are increased by the excessive renal loss of free water, resulting in thirst and polydipsia. Patients who can drink water generally compensate for the urinary losses, but patients who are obtunded, bedridden, or otherwise limited in their ability to obtain water may develop life-threatening dehydration. Syndrome of inappropriate ADH-SIOD secretion. ADH excess causes overresorption of free water, resulting in hyponatremia. The most frequent causes of SIOD are the secretion of ectopic ADH by malignant neoplasms, particularly small cell carcinoma of the lung, drugs that increase ADH secretion, and a variety of central nervous system disorders, including infections and trauma. The clinical manifestations of SIOD are dominated by hyponatremia, cerebral edema, and resultant neurologic dysfunction. Although total body water is increased, blood volume remains normal, and peripheral edema does not develop. Figure 24.7, adamantinomatous craniopharyngioma, demonstrating characteristic compact, lamellar wet keratin right half of photomicrograph, and cords of squamous epithelium with peripheral palisading on the left. Courtesy Dr. Charles Eberhardt, Department of Pathology, Johns Hopkins University, Baltimore, MD. Hypothalamic suprasellular tumors. Neoplasms in this location may induce hypofunction or hyperfunction of the anterior pituitary, diabetes insipidus, or combinations of these manifestations. The most commonly implicated tumors are glioma, sometimes arising in the chiasm, chapter 28, and craniopharyngioma. Craniopharyngioma is thought to arise from vestigial remnants of Rathke pouch. These slow-growing tumors account for 1% to 5% of intracranial tumors. A small minority of these lesions occurs within the cella, but most are suprasellar, with or without intracellular extension. A bimodal age distribution is observed, with one peak in childhood, 5 to 15 years, and a second peak in adults, 65 years of age or older. Patients usually come to attention because of headaches and visual disturbances, while children sometimes present with growth retardation due to pituitary hypofunction and GH deficiency. Morphology: craniopharyngiomas average 3 to 4 centimeters in diameter. They may be encapsulated and solid, but more commonly they are cystic and sometimes multiloculated. They often encroach on the optic chiasm or cranial nerves, and not infrequently they bulge into the floor of the third ventricle and base of the brain. Two distinct histologic variants are recognized: adamantinomatous craniopharyngioma, most often observed in children, and papillary craniopharyngioma, most often observed in adults. The adamantinomatous type frequently contains radiologically demonstrable calcifications. The papillary variant calcifies only rarely. Adamantinomatous craniopharyngioma consists of nests, or cords of stratified squamous epithelium embedded in a spongy reticulum that becomes more prominent in the internal layers. Palisading of the squamous epithelium is frequently observed at the periphery. Compact lamellar keratin formation, wet keratin, is a diagnostic feature of this tumor. Figure 24.7. As mentioned earlier, dystrophic calcification is a frequent finding. Additional features include cyst formation, fibrosis, and chronic inflammation. The cysts of adamantinomatous craniopharyngiomas often contain a cholesterol-rich, thick brownish yellow fluid that has been compared to machine oil. These tumors extend fingerlets of epithelium into adjacent brain, where they elicit a brisk glial reaction. This subtype of craniopharyngioma is characterized by recurrent mutations of the CTNNB1 beta-catenin gene, which leads to aberrant activation of the WNT signaling pathway. Papillary craniopharyngiomas contain both solid sheets of cells and papillae lined by well-differentiated squamous epithelium. Tumors usually are distinguished from the adamantinous type by the lack of lamellar keratin, calcification, cysts, peripheral palisading of squamous cells, and a spongy reticulum. Also, unlike adamantinomatous craniopharyngioma, this subtype is characterized by activating mutations of the BRAF oncogene at codon 600. The identification of BRAF-V600E mutations has therapeutic implications due to availability of small molecule BRAF inhibitor drugs that inhibit the BRAF serine 309 kinase, chapter 7. Patients with craniopharyngiomas, especially those less than 5 centimeters in diameter, have an excellent recurrence-free and overall survival. Larger lesions are more invasive, but this does not impact on the prognosis. Malignant transformation of craniopharyngiomas into squamous carcinomas is rare and usually occurs only after irradiation, 1074. Thyroid gland, 1075. Thyroid gland. The thyroid gland consists of two lateral lobes connected by a thin isthmus, usually located below and anterior to the larynx. It develops embryologically from an invagination of the pharyngeal epithelium that descends from the foramen cecum at the base of the tongue to its normal position in the anterior neck. This pattern of descent explains the occasional presence of ectopic thyroid tissue at the base of the tongue, lingual thyroid, or at other sites high in the neck. The thyroid is divided by thin fibrous septae into lobules composed of 20 to 40 follicles, lined by a cuboidal to low columnar epithelium, and filled with PA's positive thyroglobulin. In response to hypothalamic factors, TSH, thyrotropin, is released by thyrotrophs in the anterior pituitary into the circulation. The binding of TSH to its receptor on thyroid follicular epithelial cells activates the receptor, which then associates with a GS protein, figure 24.8. Activation of the G, TRH, T3, T4, TSH, pituitary, TSH receptor thyroid, hormone receptor, GG protein, GTP, GDP, T3, T4, target gene, thyroid camp, gene expression on. Figure 24.8. Homeostasis in the hypothalamus pituitary thyroid axis and mechanism of action of thyroid hormones. Secretion of thyroid hormones T3 and T4 is controlled by trophic factors secreted by both the hypothalamus and the anterior pituitary. Decreased levels of T3 and T4 stimulate the release of thyrotropin-releasing hormone TRH from the hypothalamus and thyroid-stimulating hormone TSH from the anterior pituitary, causing T3 and T4 levels to rise. Elevated T3 and T4 levels, in turn, feed back to suppress the secretion of both TRH and TSH. TSH binds to the TSH receptor on the thyroid follicular epithelium, which causes activation of G proteins, and CAMP-mediated synthesis and release of thyroid hormones T3 and T4. In the periphery, T3 and T4 interact with the thyroid hormone receptor to form a hormone receptor complex that translocates to the nucleus and binds to so-called thyroid response elements on target genes to initiate transcription. Protein triggers downstream events that increase intracellular CAMP levels, which, in turn, stimulates thyroid growth and thyroid hormone synthesis and release via CAMP-dependent protein kinases. Thyroid follicular epithelial cells convert thyroglobulin into thyroxine T4 and lesser amounts of triiodothyronine T3. T4 and T3 are released into the systemic circulation, where most of these peptide hormones are reversibly bound to circulating plasma proteins, such as thyroxine-binding globulin and transthyretin. The binding proteins act as a buffer that maintains the serum unbound free T3 and T4 concentrations within narrow limits, while ensuring that adequate amounts of the hormones are readily available to the tissues. In the periphery, the majority of free T4 is deiodinated to T3. The latter binds to thyroid hormone nuclear receptors in target cells, with 10-fold greater affinity than does T4, and has proportionately greater activity. Binding of thyroid hormone to its nuclear thyroid hormone receptor TR results in the assembly of a multi-protein hormone receptor complex on thyroid hormone response elements TRES near target genes, increasing their transcription. See figure 24.8. Thyroid hormone has diverse cellular effects, including the stimulation of carbohydrate and lipid catabolism and protein synthesis in a wide range of cells. The net result is an increase in the basal metabolic rate. In addition, thyroid hormone has a critical role in brain development in the fetus and neonate. See later. The function of the thyroid gland can be inhibited by a variety of chemical agents, collectively referred to as goitrogens. Because they suppress T3 and T4 synthesis, the level of TSH increases, causing subsequent hyperplastic enlargement of the gland goiter. The anti-thyroid agent propylthiouracil inhibits the oxidation of iodide and thus blocks the production of thyroid hormones. Propylthiouracil also inhibits the peripheral deiodination of circulating T4 into T3, thus ameliorating symptoms of thyroid hormone excess. See later. Iodide, when given in large doses to individuals with thyroid hyperfunction, blocks the release of thyroid hormones by inhibiting the proteolysis of thyroglobulin. Thus, thyroid hormone is synthesized and incorporated into colloid, but it is not released into the blood. The thyroid gland follicles also contain a population of parafollicular cells, or C cells, which synthesize and secrete the hormone calcitonin. This hormone promotes the absorption of calcium by the skeletal system and inhibits the resorption of bone by osteoclasts. Diseases of the thyroid include conditions associated with excessive release of thyroid hormones, hyperthyroidism, thyroid hormone deficiency, hypothyroidism, and mass lesions of the thyroid. We will first consider the clinical consequences of disturbed thyroid function, and then turn to the disorders that generate these problems. Hyperthyroidism. Thyrotoxicosis is a hypermetabolic state caused by elevated circulating levels of free T3 and T4. Because it is caused, 1076, Chapter 24, the endocrine system. Table 24.3 disorders associated with thyrotoxicosis, associated with hyperthyroidism, primary. Diffuse hyperplasia Graves' disease, hyperfunctioning toxic, multinodular goiter hyperfunctioning toxic adenoma, iodine-induced hyperthyroidism, neonatal thyrotoxicosis, associated with maternal Graves' disease. Secondary. TSH secreting pituitary adenoma rarea, not associated with hyperthyroidism, granulomatous dicrovane thyroiditis, painful subacute lymphocytic thyroiditis, painless, struma ovarii ovarian teratoma with ectopic thyroid. Factitious thyrotoxicosis, exogenous thyroxine intake, associated with increased thyroid stimulating hormone TSH. All other causes of thyrotoxicosis associated with decreased TSH, most commonly by hyperfunction of the thyroid gland, it is often referred to as hyperthyroidism. However, in certain conditions, the oversupply is related to either excessive release of preformed thyroid hormone, e.g. in thyroiditis, or to an extrathyroidal source, rather than hyperfunction of the gland. Table 24.3. Thus, strictly speaking, hyperthyroidism is only one, albeit the most common cause of thyrotoxicosis. The terms primary and secondary hyperthyroidism are sometimes used to designate hyperthyroidism arising from an intrinsic thyroid abnormality and that arising from processes outside of the thyroid, such as a TSH-secreting pituitary tumor. With this caveat, we follow the common practice of using the terms thyrotoxicosis and hyperthyroidism interchangeably. The most common causes of thyrotoxicosis are associated with hyperfunction of the gland and include the following. Diffuse hyperplasia of the thyroid associated with Graves' disease, approximately 85% of cases. Hyperfunctional multinodular goiter, hyperfunctional thyroid adenoma. Clinical features. The manifestations of hyperthyroidism are protean and include changes referable to the hypermetabolic state induced by excess thyroid hormone and to overactivity of the sympathetic nervous system, i.e., an increase in the beta-adrenergic tone. Excessive levels of thyroid hormone result in an increase in the basal metabolic rate. The skin of thyrotoxic patients tends to be soft, warm, and flushed because of increased blood flow and peripheral vasodilation, adaptations that serve to increase heat loss. Heat intolerance is common. Sweating is increased because of higher levels of calorigenesis. Heightened catabolic metabolism results in weight loss despite increased appetite. Cardiac manifestations are among the earliest and most consistent features. Individuals with hyperthyroidism can have elevated cardiac contractility and output, a response to increased peripheral oxygen requirements. Tachycardia, palpitations, and cardiomegaly are common. Arrhythmias such as atrial fibrillation occur frequently, particularly in older patients. Congestive heart failure. Figure 24.9. A person with hyperthyroidism. A wide-eyed, staring gaze caused by overactivity of the sympathetic nervous system is one feature of this disorder. In Graves' disease, an important cause of hyperthyroidism, accumulation of loose connective tissue behind the orbit also adds to the protuberant appearance of the eyes. May develop, especially in older adults with pre-existing cardiac disease. Myocardial changes, including focal lymphocytic and eosinophilic infiltrates, mild fibrosis, myofibril fatty change, and an increase in size and number of mitochondria have been described. Some individuals with thyrotoxicosis develop reversible left ventricular dysfunction and low-output heart failure, so-called thyrotoxic or hyperthyroid cardiomyopathy. Overactivity of the sympathetic nervous system produces tremor, hyperactivity, emotional lability, anxiety, inability to concentrate, and insomnia. Proximal muscle weakness and decreased muscle mass are common thyroid myopathy. In the gastrointestinal system, hypermotility and reduced transit times lead to hyperdefecation, not to be confused with diarrhea, which typically responds to beta blockers, suggesting sympathetic hyperstimulation is the likely underlying pathophysiology. Most patients also develop some degree of fat malabsorption. Ocular changes often call attention to hyperthyroidism. A wide, staring gaze and lid lag are present because of sympathetic overstimulation of the superior tarsal muscle, also known as Muller's muscle, which functions alongside the levator palpebrae superioris muscle to raise the upper eyelid, figure 24.9. However, true thyroid ophthalmopathy associated with proptosis occurs only in Graves' disease, see later. The skeletal system is also affected. Thyroid hormone stimulates bone resorption, increasing cortical bone porosity and reducing trabecular bone volume. The net effect is osteoporosis and an increased risk of fractures. Other findings include atrophy of skeletal muscle, with fatty infiltration and focal interstitial lymphocytic infiltrates, hepatic fatty chain steatosis leading to mild hepatomegaly, and generalized lymphoid hyperplasia and lymphadenopathy in patients with Graves' disease. Thyroid storm refers to the abrupt onset of severe hyperthyroidism. This condition occurs most commonly in patients with Graves' disease and probably results from an acute elevation in catecholamine levels, as might be. Thyroid gland 1077. Encountered during infection, surgery, cessation of antithyroid medication, or any form of stress. Patients are often febrile and present with tachycardia out of proportion to the fever. Thyroid storm is a medical emergency. A significant number of untreated patients die of cardiac arrhythmias. Apathetic hyperthyroidism refers to thyrotoxicosis occurring in older adults, in whom advanced age and various comorbidities blunt the typical features of thyroid hormone excess. The diagnosis in these individuals is often made during laboratory workup for unexplained weight loss or worsening cardiovascular disease. Laboratory findings that support the diagnosis of hyperthyroidism include a low TSH value accompanied by an increase in free T4. The measurement of serum TSH concentration is the most useful single screening test for hyperthyroidism because its levels are decreased even at the earliest stages, when the disease may still be subclinical. In occasional patients, hyperthyroidism results predominantly from increased circulating levels of T3 toxicosis. In these cases, free T4 levels may be decreased, and direct measurement of serum T3 is useful. In rare cases of pituitary-associated secondary hyperthyroidism, TSH levels are either normal or raised. Determining TSH levels after the injection of thyrotropin-releasing hormone TRH stimulation test is used in the evaluation of cases of suspected hyperthyroidism with equivocal changes in the baseline serum TSH level. A normal rise in TSH after administration of TRH excludes secondary hyperthyroidism. Once a diagnosis of thyrotoxicosis has been confirmed by a combination of TSH assays and free thyroid hormone levels, measurement of radioactive iodine uptake by the thyroid gland can help determine the etiology. For example, there may be diffusely increased uptake in the gland Graves' disease, increased uptake in a solitary nodule toxic adenoma, or decreased uptake thyroiditis. The therapeutic options for hyperthyroidism include several medications, each with a different mechanism of action. Typically, these include a beta blocker to control symptoms induced by increased adrenergic tone, a thionamide e.g. methimazole or propylthiouracil to block new hormone synthesis, an iodine solution to block the release of thyroid hormone, and agents that inhibit peripheral conversion of T4 to T3. Radioactive iodine, which is incorporated into thyroid tissues, resulting in ablation of thyroid function over a period of 6 to 18 weeks, may also be used. Hypothyroidism. Hypothyroidism is a condition caused by a structural or functional derangement that interferes with the production of thyroid hormone. Hypothyroidism is a common disorder. By some estimates, the prevalence of overt hypothyroidism is 0.3%, while that of subclinical hypothyroidism is greater than 4%. The prevalence increases with age, and it is nearly 10-fold more common in women than in men. Hypothyroidism can result from a defect anywhere in the hypothalamic pituitary thyroid axis. Like hyperthyroidism, it can be divided into primary and secondary forms, depending on whether it arises from an intrinsic thyroid abnormality of hypothyroidism. Genetic defects in thymery. Genetic defects in thyroid development. PAX8 FOX1 TSH receptor mutations rare. Thyroid hormone resistance syndrome (THRB) mutations rare. Postablative surgery, radioiodine therapy, or external irradiation Autoimmune hypothyroidism. Hashimoto thyroiditis iodine deficiency drugs, lithium iodides. P-aminosalicylic acid. Congenital biosynthetic defect. Dys-hormonogenetic goiter, RARA. Secondary, central hypothyroidism. Pituitary failure, rare. Hypothalamic failure, rare. Associated with enlargement of thyroid, goitrous hypothyroidism. Hashimoto thyroiditis and postablative hypothyroidism account for the majority of cases of hypothyroidism in high-income countries. FOX1, forkhead box E1, PAX8, paired box 8, THRB, thyroid hormone receptor beta. Causes. Or as a result of pituitary and hypothalamic disease, table 24.4. Primary hypothyroidism accounts for the vast majority of cases and may be accompanied by enlargement of the thyroid gland, goiter. Primary hypothyroidism can be congenital, autoimmune, or iatrogenic. Congenital hypothyroidism. Worldwide, congenital hypothyroidism is most often the result of endemic iodine deficiency in the diet. See later. Other rare forms of congenital hypothyroidism include inborn errors of thyroid metabolism, dys-hormonogenetic goiter, wherein one of the several steps leading to thyroid hormone synthesis is defective, such as 1. Iodide transport into thyrocytes, 2. Organification of iodine, covalent binding of iodine to tyrosine residues in thyroglobulin, and 3. Further processing to form hormonally active T3 and T4. In rare instances, there may be complete absence of thyroid parenchyma thyroidogenesis, or the gland may be greatly reduced in size thyroid hypoplasia due to germline mutations in genes responsible for thyroid development. See table 24.4. Autoimmune hypothyroidism. Autoimmune hypothyroidism is the most common cause of hypothyroidism in iodine-insufficient areas of the world. The vast majority of cases of autoimmune hypothyroidism are due to Hashimoto thyroiditis. Circulating autoantibodies, including antimicrosomal, antithyroid peroxidase, and antithyroglobulin antibodies, are found in this disorder, and the thyroid is typically enlarged, goitrous. Autoimmune hypothyroidism can occur in isolation or in conjunction with autoimmune polyendocrine syndrome, types 1 and 2, APS1 and APS2. See discussion in the adrenal glands section later in this chapter. Iatrogenic hypothyroidism. This can be caused by either surgical or radiation-induced ablation. Resection of a large portion of the gland for the treatment of hyperthyroidism or a primary neoplasm can lead to hypothyroidism. The gland may also be ablated by radiation, whether in the form of radioiodine administered for the treatment of hyperthyroidism or exogenous irradiation, such as external radiation therapy to the neck. Drugs given to decrease thyroid secretion, e.g., thienamides like methimazole and 1078, Chapter 24. The propylthiouracil can also cause acquired hypothyroidism, as can agents used to treat non-thyroid conditions, e.g., lithium, p-aminosalicylic acid. Secondary or central hypothyroidism is caused by deficiencies of TSH, or, far more uncommonly, TRH. Any of the causes of hypopituitarism, e.g., pituitary tumor, postpartum pituitary necrosis, trauma, and non-pituitary tumors, or hypothalamic damage, e.g., tumors, trauma, radiation therapy, or infiltrative diseases, can cause central hypothyroidism. Cretinism. Cretinism refers to hypothyroidism that develops in infancy or early childhood. The term cretin was derived from the French chrétien, meaning Christian or Christ-like, and was applied to those affected because they were felt to be too mentally challenged to be capable of sinning. In the past, this disorder occurred fairly commonly in regions of the world where dietary iodine deficiency is endemic, such as the Himalayas, inland China, Africa, and other mountainous areas. It is now much less prevalent as a result of the widespread supplementation of foods with iodine. On rare occasions, cretinism results from genetic defects that interfere with the biosynthesis of thyroid hormone, dys-hormonogenetic goiter. Clinical features of cretinism include severe intellectual disability, short stature, coarse facial features, a protruding tongue, and umbilical hernia. The severity of the mental impairment seems to be related to the time at which thyroid deficiency occurs in utero. Normally, maternal T3 and T4 cross the placenta and are critical for fetal brain development. If there is maternal thyroid deficiency before the development of the fetal thyroid gland, intellectual disability is severe. In contrast, maternal thyroid hormone deficiency later in pregnancy, after the fetal thyroid has become functional, does not affect normal brain development. Myxedema. The term myxedema is applied to hypothyroidism developing in the older child or adult. Myxedema was first linked with thyroid dysfunction in 1873 by Sir William Gull in an article addressing the development of a cretinoid state in adults. The clinical findings vary with age of onset. Older children show signs and symptoms intermediate between those of the cretin and those of the adult with hypothyroidism. In the adult, the condition appears insidiously and may take years before arousing clinical suspicion. Myxedema is marked by a slowing of physical and mental activity. Early symptoms include generalized fatigue, apathy, and mental sluggishness, which may mimic depression. Speech and intellectual functions are slowed, and patients are listless, cold intolerant, and frequently overweight. Decreased sympathetic activity results in constipation and decreased sweating. The skin is cool and pale because of decreased blood flow. Reduced cardiac output probably contributes to shortness of breath and decreased exercise capacity. 2 frequent complaints. Thyroid hormones regulate the transcription of several sarcolemmal genes such as calcium apases and the beta-adrenergic receptor, and diminished expression of these genes results in a decrease in cardiac output. In addition, changes in lipid metabolism produce an increase in total cholesterol and low-density lipoprotein LDL levels that is pro-atherogenic, contributing to increased cardiovascular mortality. Histologically, there is an accumulation of matrix substances, such as glycosaminoglycans and hyaluronic acid, in skin, subcutaneous tissue, and visceral sites. This results in non-pitting edema, a broadening and coarsening of facial features, enlargement of the tongue, and deepening of the voice. Laboratory evaluation plays a vital role in the diagnosis of suspected hypothyroidism because of the nonspecific nature of symptoms. Patients with unexplained increases in body weight or hypercholesterolemia should be assessed for potential hypothyroidism. Measurement of the serum TSH level is the most sensitive screening test for this disorder. The TSH level is increased in primary hypothyroidism as a result of a loss of feedback inhibition of TRH and TSH production by the hypothalamus and pituitary, respectively. The TSH level is not increased in persons with hypothyroidism due to primary hypothalamic or pituitary disease. T4 levels are decreased in individuals with hypothyroidism of any origin. Thyroiditis encompasses a diverse group of disorders characterized by some form of thyroid inflammation. This discussion focuses on the three most common and clinically significant subtypes: 1. Hashimoto thyroiditis, 2. Granulomatous decurvain thyroiditis, and 3. Subacute lymphocytic thyroiditis. Hashimoto thyroiditis. Hashimoto thyroiditis is an autoimmune disease that results in destruction of the thyroid gland and gradual and progressive thyroid failure. It is the most common cause of hypothyroidism in areas of the world where iodine levels are sufficient. The name is derived from the 1912 report by Hashimoto describing patients with goiter and lymphocytic infiltration of the thyroid struma lymphomatosa. It is most prevalent between 45 and 65 years of age and is more common in women than in men, with a female predominance of 10:1 to 20:1. It can also occur in children and is a major cause of non-endemic goiter in the pediatric population. Pathogenesis. Hashimoto thyroiditis is caused by a breakdown in self-tolerance to thyroid autoantigens. This is exemplified by the presence of circulating autoantibodies against thyroglobulin and thyroid peroxidase in the vast majority of patients. The inciting events have not been elucidated, but possibilities include abnormalities of regulatory T cells, TREGs, or exposure of normally sequestered thyroid antigens, Chapter 6. Similar to other autoimmune diseases, Hashimoto thyroiditis predisposition has a strong genetic component. Increased susceptibility is associated with polymorphisms in several immune regulation-associated genes, such as cytotoxic T lymphocyte-associated antigen 4. Thyroid gland 1079, thyroid epithelium, breakdown in self-tolerance and induction of thyroid autoimmunity, MHC, CD8 plus cytotoxic T cell, CD4 plus Th1 cell, IFN gamma. Activated macrophages, plasma cell, anti-thyroid antibodies, T cell, mediated cytotoxicity FC receptor, NK cell, thyrocyte injury, antibody-dependent cell, mediated cytotoxicity. Figure 24.10 Pathogenesis of Hashimoto thyroiditis. Breakdown of peripheral tolerance to thyroid autoantigens results in progressive autoimmune destruction of thyroid cells by infiltrating cytotoxic T cells, locally released cytokines, or antibody-dependent cytotoxicity. CTLA4. Protein tyrosine phosphatase 22 PTPN22 and interleukin-2 receptor alpha chain, EL2RA, all of which encode regulators of T cell responses. Not surprisingly, genome-wide association studies, GWAS, have found similar associations between CTLA4, PTPN22, and IL2RA polymorphisms in Graves' disease, another type of autoimmune thyroid disease discussed later, as well as with other systemic autoimmune diseases such as type 1 diabetes, tone D. The genetic associations support the idea that breakdown in immune tolerance is a common pathophysiologic theme for many autoimmune diseases, more than one of which can coexist in the same individual. Induction of thyroid autoimmunity is accompanied by a progressive depletion of thyroid epithelial cells and replacement of the thyroid parenchyma by lymphocytic infiltrates and fibrosis. Multiple immunologic mechanisms may contribute to thyroid cell death, including Figure 24:10. CD8 plus cytotoxic T cell mediated cell death. CD8 plus cytotoxic T cells may destroy thyroid follicular cells. Cytokine mediated cell death, activation of CD4 plus DA1 cells leads to the production of inflammatory cytokines such as interferon gamma in the thyroid gland, with resultant recruit, extensive infiltration of the parenchyma by a mononuclear ment and activation of macrophages, and damage to inflammatory infiltrate containing small lymphocytes, plasma follicles. Cells and well-developed germinal centers, Figure 24:11. The less likely mechanism involves binding of antithyroid. Thyroid follicles are atrophic and are lined in many areas by epithelial antibodies, antithyroglobulin, and antithyroid peroxidase cells with abundant eosinophilic, granular cytoplasm, termed antibodies, followed by antibody-dependent cell-mediated Hürthle cells, which represent a metaplastic response of the cytotoxicity. Chapter 6. Normally low cuboidal follicular epithelium to chronic injury. In fine needle aspiration biopsy samples, the presence of Hürthle cells in conjunction with a heterogeneous population of lymphocytes is characteristic of Hashimoto thyroiditis. In classic Hashimoto thyroiditis, interstitial connective tissue is increased and may be abundant. Unlike Riedel thyroiditis, see later, the surface is pale, yellow-tan, firm, and somewhat nodular. There is fibrosis does not extend beyond the capsule of the gland. Figure 24.1, 1 Hashimoto thyroiditis. The thyroid parenchyma contains a dense lymphocytic infiltrate with germinal centers. Residual thyroid follicles lined by deeply eosinophilic Hürthle cells are also seen. Morphology. The thyroid is usually diffusely enlarged. The capsule is intact and the gland is well demarcated from adjacent structures. The cut, 1080, Chapter 24, the endocrine system. Clinical features Hashimoto thyroiditis most often comes to attention as painless enlargement of the thyroid, usually associated with some degree of hypothyroidism. In a middle-aged woman, the enlargement of the gland is generally symmetric and diffuse, but in some cases it may be sufficiently localized to raise the suspicion of a neoplasm. In the typical case, hypothyroidism develops gradually. In some patients, however, it may be preceded by transient thyrotoxicosis caused by disruption of thyroid follicles and release of thyroid hormones, hashitoxicosis. During this phase, free T4 and T3 levels are elevated, TSH is diminished, and radioactive iodine uptake is decreased. As hypothyroidism supervenes, T4 and T3 levels fall, accompanied by a compensatory increase in TSH. Individuals with Hashimoto thyroiditis are at increased risk for developing other autoimmune diseases, both endocrine type 1 diabetes, autoimmune adrenalitis, and non-endocrine systemic lupus erythematosus, myasthenia gravis, and Sjogren's syndrome, Chapter 6. They are also at increased risk for development of extranodal marginal zone B-cell lymphoma within the thyroid gland, Chapter 13. The relationship between Hashimoto disease and thyroid epithelial cancers remains controversial, with some morphologic and molecular studies suggesting a predisposition to papillary carcinoma. Subacute lymphocytic painless thyroiditis. Subacute lymphocytic thyroiditis, which is also referred to as painless thyroiditis, is a presumed autoimmune disease. Most patients have circulating anti-thyroid peroxidase antibodies or a family history of other autoimmune disorders. A similar disease process can occur during the postpartum period in up to 5% of women postpartum thyroiditis. Age, and, like other forms of thyroiditis, affects women more often than men. 4.1. Pathogenesis granulomatous thyroiditis is believed to be triggered by a viral infection. The majority of patients have a history of an upper respiratory infection just before the onset of thyroiditis. The disease is seasonal, with occurrences peaking in the summer, and clusters of cases have been reported in association with Coxsackie virus, mumps, measles, adenovirus, and other viral infections. Although the pathogenesis of the disease is unclear, one model suggests that it results from virus-induced host tissue damage that stimulates a cytotoxic T lymphocyte response to one or more thyroid antigens that damages thyroid follicle cells. In contrast to autoimmune thyroid disease, the immune response is virus-initiated and not self-perpetuating, so the process is limited. Morphology. The gland may be unilaterally or bilaterally enlarged and firm, with an intact capsule that may adhere to surrounding structures. On cut section, the involved areas are firm and yellow-white and stand out from adjacent normal rubbery brown thyroid gland. Histologic changes are patchy and depend on the stage of the disease. Early in the active inflammatory phase, scattered follicles may be disrupted and replaced by neutrophils forming microabscesses. Later, more characteristic features appear in the form of aggregates of lymphocytes, activated macrophages, and plasma cells associated with collapsed and damaged thyroid follicles. Multinucleate giant cells enclose pools of colloid, figure 24.12, hence the designation granulomatous thyroiditis. In later stages of the disease, a chronic inflammatory infiltrate and fibrosis may replace the foci of injury. Different histologic stages are sometimes found in the same gland, suggesting waves of destruction over a period of time. Morphology. Clinical features. Granulomatous thyroiditis is the most common cause of thyroid pain. There is variable enlargement of the gland, inflammation of the thyroid, and hyperthyroidism are. Except for possible mild symmetric enlargement, the thyroid appears grossly normal. Microscopic examination reveals lymphocytic infiltration with large germinal centers within the thyroid parenchyma and patchy disruption and collapse of thyroid follicles. Unlike Hashimoto thyroiditis, however, fibrosis and Hürthle cell metaplasia are not prominent. Clinical features. Painless thyroiditis usually comes to attention because of mild, transient hyperthyroidism, painless goiter, or both. Although it can occur at any age, it is most often seen in middle-aged adults and is more common in women. Some patients transition from hyperthyroidism to hypothyroidism before recovery. As many as 1/3 of cases evolve into overt hypothyroidism over a 10-year period, with pathologic features that resemble Hashimoto thyroiditis. Granulomatous thyroiditis. Granulomatous thyroiditis, also called de Quervain thyroiditis, occurs much less frequently than does Hashimoto thyroiditis. The disorder is most common between 40 and 50 years of. Figure 24.1. Granulomatous thyroiditis. The thyroid parenchyma contains a chronic inflammatory infiltrate with a multinucleate giant cell top left and a colloid follicle bottom right. Thyroid gland 1081. Transient, usually diminishing in 2 to 6 weeks, even if the patient is not treated. Nearly all patients have high serum T4 and T3 levels and low serum TSH levels during this phase. However, unlike in hyperthyroid states such as Graves' disease, radioactive iodine uptake is diminished. After recovery, generally in 6 to 8 weeks, normal thyroid function returns. Other, less common forms of thyroiditis include renal thyroiditis, a rare disorder characterized by extensive fibrosis involving the thyroid and contiguous neck structures. The presence of a hard and fixed thyroid mass clinically simulates a thyroid carcinoma. It may be associated with fibrosis in other sites in the body, such as the retroperitoneum, and appears to be another manifestation of IgG4-related disease, which is associated with fibrosis and tissue infiltration by plasma cells, producing IgG4, Chapter 6. Key concepts. Thyroiditis. Hashimoto thyroiditis is the most common cause of hypothyroidism in regions where dietary iodine levels are sufficient. Hashimoto thyroiditis is an autoimmune thyroiditis characterized by progressive destruction of thyroid parenchyma, Hürthle cell, change and mononuclear lymphoplasmacytic infiltrates, with germinal centers and variable degrees of fibrosis. Subacute lymphocytic thyroiditis often occurs after pregnancy. Postpartum thyroiditis typically is painless and is characterized by lymphocytic inflammation in the thyroid. It is another type of autoimmune thyroiditis. Granulomatous de Quervain thyroiditis is a self-limited disease, probably secondary to a viral infection, and is characterized by pain and granulomatous inflammation of the thyroid. Graves' disease. Graves' disease is the most common cause of endogenous hyperthyroidism. Graves reported in 1835 his observations of a disease characterized by violent and long-continued palpitations in females associated with enlargement of the thyroid gland. The disease is characterized by a triad of clinical findings: hyperthyroidism associated with diffuse enlargement of the gland, infiltrative ophthalmopathy, and resultant exophthalmos. Localized infiltrative dermopathy, sometimes called pertibial myxedema, which is present in a minority of patients. Graves' disease has a peak incidence between 20 and 40 years of age. Women are affected as much as 10 times more frequently than men. This disorder is said to affect 1.5% to 2% of women in the United States. Pathogenesis. Graves' disease is an autoimmune disorder characterized by the production of autoantibodies against multiple thyroid proteins, most importantly the TSH receptor. A variety of antibodies that either stimulate or block the TSH receptor are detected in the circulation. The most common antibody subtype, known as thyroid-stimulating immunoglobulin TSI, is observed in approximately 90% of patients. In contrast to antibodies against thyroglobulin and thyroid peroxidase, TSI is almost never observed in other autoimmune diseases of the thyroid. TI binds to the TSH receptor and mimics its actions, stimulating adenyl cyclase and increasing the release of thyroid hormones. As stated earlier, TSH receptor blocking antibodies may also be present, and in a minority of patients, these lead to hypothyroidism. Perhaps unsurprisingly, factors that predispose to Graves' disease overlap with risk factors for Hashimoto thyroiditis, the other major form of autoimmune thyroid disease. The concordance rate in monozygotic twins is 30% to 40%, compared with less than 5% among dizygotic twins, and similar to Hashimoto thyroiditis. Genetic susceptibility is associated with polymorphisms in immune function genes like CTLA4, PTPN22, and IL2RA. In addition, GWAS data has also implicated variants in the TSH receptor, TSHR, gene locus in susceptibility to Graves' disease. Autoimmunity also plays a role in the development of the infiltrative ophthalmopathy that is characteristic of Graves' disease. Activated CD4+ helper T cells secrete cytokines that stimulate fibroblast proliferation and synthesis of extracellular matrix proteins, glycosaminoglycans, leading to progressive infiltration of the retroorbital space and ophthalmopathy. The protrusion of the eyeball exophthalmos is caused by an increase in the volume of the retroorbital connective tissues and extraocular muscles, which occurs for several reasons. 1. Marked infiltration of connective tissue by mononuclear cells, predominantly T cells. 2. Inflammation, edema, and swelling of extraocular muscles. 3. Accumulation of extracellular matrix components, specifically hydrophilic glycosaminoglycans such as hyaluronic acid and chondroitin sulfate. And 4. Increased numbers of adipocytes, fatty infiltration. These changes not only displace the eyeball, but also may interfere with the function of the extraocular muscles. Morphology. The thyroid gland is usually symmetrically enlarged due to diffuse hypertrophy and hyperplasia of thyroid follicular epithelial cells. Figure 24.13a. Increases in weight to over 80 grams are not uncommon. On cut section, the parenchyma has a soft, meaty appearance resembling muscle. Histologically, the follicle epithelial cells in untreated cases are tall and more crowded than usual. This crowding often results in the formation of small papillae that project into the follicle lumen and encroach on the colloid, sometimes filling the follicles. Figure 24. Such papillae lack fibrovascular cores, in contrast to those of papillary carcinoma. See later. The colloid within the follicle lumen is pale with scalloped margins. Lymphoid infiltrates, consisting predominantly of T cells, along with scattered B cells and mature plasma cells, are present throughout the interstitium. Germinal centers are common. Preoperative therapy alters the morphology of the thyroid in Graves' disease. Administration of iodine causes involution of the epithelium and the accumulation of colloid by blocking thyroglobulin secretion. Treatment with the antithyroid drug propylthiouracil exaggerates the epithelial hypertrophy and hyperplasia by stimulating TSH secretion. Changes in extrathyroidal tissue include lymphoid hyperplasia, especially enlargement of the thymus in younger patients. The 1082, Chapter 24, the endocrine system. A B, Figure 24, Graves' disease. A. There is diffuse symmetric enlargement of the gland and a beefy deep red parenchyma. Compare with gross photograph of multinodular goiter in Figure 24. 15. B. Diffusely hyperplastic thyroid in a case of Graves' disease. The follicles are lined by tall columnar epithelium. The crowded, enlarged epithelial cells project into the lumens of the follicles. These cells actively resorb the colloid in the centers of the follicles, resulting in the scalloped appearance of the edges of the colloid. A. Reproduced with permission from Lloyd R.V., Douglas B.R., Young W.F. Jr. Editors, Atlas of Non-Tumor Pathology, Endocrine Diseases, Washington, D.C., 2002, American Registry of Pathology. Graves' disease is treated with beta blockers, which dampen symptoms related to increased sympathetic nervous system activity, e.g., tachycardia, palpitations, tremulousness, and anxiety, and by measures that decrease thyroid hormone synthesis, such as the administration of thienamides, e.g., propylthiouracil, radioiodine ablation, and thyroidectomy. Surgery is used mostly in patients who have large goiters that are compressing surrounding structures. Heart may be hypertrophied, and ischemic changes may be present, particularly in patients with pre-existing coronary artery disease. In patients with ophthalmopathy, the tissues of the orbit are edematous because of the presence of hydrophilic mucopolysaccharides. In addition, there is infiltration by lymphocytes and fibrosis. Orbital muscles are edematous initially but may undergo fibrosis late in the course of the disease. The dermopathy, if present, is characterized by thickening of the dermis due to deposition of glycosaminoglycans and lymphocyte infiltration. Clinical features. The findings in Graves' disease include changes associated with thyrotoxicosis and others associated uniquely with Graves' disease, such as diffuse hyperplasia of the thyroid, ophthalmopathy, and dermopathy. The degree of thyrotoxicosis varies from case to case and is sometimes less conspicuous than other manifestations of the disease. Diffuse enlargement of the thyroid is present in all cases. The thyroid enlargement may be accompanied by increased flow of blood through the hyperactive gland, often producing an audible bruit. Sympathetic overactivity produces a characteristic wide, staring gaze and lid lag, while the ophthalmopathy causes exophthalmos. The exophthalmos may persist or progress despite successful treatment of the thyrotoxicosis, sometimes resulting in corneal injury. The extraocular muscles are often weak. The infiltrative dermopathy pretibial myxedema is most common in the skin overlying the shins, where it presents as scaly thickening and induration. The basis of such localization is not clear, and it is present only in a minority of patients. Sometimes individuals spontaneously develop thyroid hypofunction. Patients are at increased risk for other autoimmune diseases, such as systemic lupus erythematosus, pernicious anemia, type 1 diabetes, and Addison disease. Laboratory findings in Graves' disease include elevated free T4 and T3 levels and depressed TSH levels. Because of ongoing stimulation by thyroid-stimulating immunoglobulins, radioiodine scans show a diffusely increased uptake of iodine in the thyroid gland. Key concepts: Graves' disease. Graves' disease, the most common cause of endogenous hyperthyroidism, is characterized by the triad of thyrotoxicosis, ophthalmopathy, and dermopathy. Graves' disease is an autoimmune disorder caused by activation of thyroid epithelial cells by autoantibodies to the TSH receptor that mimic TSH action, thyroid-stimulating immunoglobulins. The thyroid in Graves' disease shows diffuse hypertrophy and hyperplasia of follicles and lymphoid infiltrates. Glycosaminoglycan deposition and lymphoid infiltrates are responsible for the ophthalmopathy and dermopathy. Laboratory features include elevations in serum free T3 and T4 and decreased serum TSH, diffuse and multinodular goiter. Enlargement of the thyroid or goiter is caused by impaired synthesis of thyroid hormone, which is most often the result of dietary iodine deficiency. Reduced thyroid hormone production leads to a compensatory rise in the serum TSH level, which in turn causes hypertrophy and hyperplasia of thyroid follicular cells, and ultimately, enlargement of the thyroid gland. This increase in functional mass of the gland usually overcomes the hormone deficiency, ensuring a euthyroid metabolic state in most individuals. If the underlying disorder is sufficiently severe, gland 1083, e.g., a congenital biosynthetic defect or endemic iodine deficiency discussed later, the compensatory responses may be inadequate, resulting in goitrous hypothyroidism. The degree of thyroid enlargement is proportional to the level and duration of thyroid hormone deficiency. Goiters can broadly be divided into two types: diffuse non-toxic and multinodular. Diffuse non-toxic simple goiter. Diffuse non-toxic simple goiter causes enlargement of the entire gland without producing nodularity. Because the enlarged follicles are filled with colloid, the term colloid goiter has been applied to this condition. This disorder occurs in both an endemic and a sporadic distribution. Endemic goiter occurs in geographic areas where the soil, water, and food supply contain low levels of iodine. The term endemic is used when goiters are present in more than 10% of the population in a given region. Such conditions are particularly common in mountainous areas of the world, including the Andes and Himalayas, where iodine deficiency is widespread. The lack of iodine leads to decreased synthesis of thyroid hormone and a compensatory increase in TSH, leading to follicular cell hypertrophy and hyperplasia and goitrous enlargement. With increasing dietary iodine supplementation, the frequency and severity of endemic goiter have declined significantly, although as many as 200 million people worldwide continue to be at risk for severe iodine deficiency. Variations in the prevalence of endemic goiter in regions with similar levels of iodine deficiency point to the existence of other causative influences, particularly dietary substances, referred to as goitrogens. The ingestion of substances that interfere with thyroid hormone synthesis at some level, such as vegetables belonging to the Brassicaceae cruciferae family, e.g. cabbage, cauliflower, Brussels sprouts, turnips, and cassava, has been documented to be goitrogenic. Native populations subsisting on cassava root are particularly at risk. Cassava contains a thiocyanate that inhibits iodide transport within the thyroid, worsening any concurrent iodine deficiency. Sporadic goiter occurs less frequently than does endemic goiter. There is a striking female preponderance and a peak incidence at puberty or in young adult life. Sporadic goiter can be caused by several conditions, including the ingestion of substances that interfere with thyroid hormone synthesis. In other instances, goiter may result from hereditary enzymatic defects that interfere with thyroid hormone synthesis, all transmitted as autosomal recessive conditions, DISH or monogenetic goiter, see earlier. In most cases, however, the cause of sporadic goiter is not apparent. By crowded columnar cells which may pile up and form projections similar to those seen in Graves' disease. The accumulation is not uniform throughout the gland, and some follicles are hugely distended, whereas others remain small. If dietary iodine subsequently increases, or if the demand for thyroid hormone decreases, the stimulated follicle epithelium involutes to form an enlarged colloid-rich gland, colloid goiter. In these cases, the cut surface of the thyroid is usually brown, somewhat glassy, and translucent. Histologically, the follicle epithelium is flattened and cuboidal, and colloid is abundant during periods of involution. Clinical features: as stated earlier, most persons with simple goiters are clinically euthyroid. Therefore, the clinical manifestations are primarily related to mass effects from the enlarged thyroid gland, figure 24.14. Although serum T3 and T4 levels are normal, the serum TSH is usually elevated or at the upper range of normal, as is expected in marginally euthyroid individuals. In children, DISH or monogenetic goiter, caused by a congenital biosynthetic defect, may induce cretinism. Multinodular goiter. With time, recurrent episodes of hyperplasia and involution combine to produce a more irregular enlargement of the thyroid termed multinodular goiter. Virtually all long-standing simple goiters convert into multinodular goiters. Multinodular goiters produce the most extreme thyroid enlargements and are more frequently mistaken for neoplasms than any other form of thyroid disease. Because they derive from simple goiter, they occur in both sporadic and endemic. Morphology, 2 phases can be identified in the evolution of diffuse non-toxic goiter, the hyperplastic phase and the phase of colloid involution. In the hyperplastic phase, the thyroid gland is diffusely and symmetrically enlarged, although the increase is usually modest, and the gland rarely exceeds 100 to 150 grams. The follicles are lined. Figure 24.1. For a 52-year-old woman with a huge colloid goiter who developed compressive symptoms. Reproduced with permission from Lloyd R.V., Douglas B.R., Young W.F. Jr., editors, Atlas of Non-Tumor Pathology, Endocrine Diseases, Washington, D.C., 2002, American Registry of Pathology. Thyroid. Chapter 24. The endocrine system. Forms having the same female-to-male distribution and presumably the same origins but affecting older individuals because they are late complications. Pathogenesis. It is believed that multinodular goiters arise because of variations among follicular cells in their response to external stimuli, such as trophic hormones. If some cells in a follicle have a growth advantage, perhaps because of acquired genetic abnormalities similar to those that give rise to adenomas, they may begin to proliferate autonomously, producing a nodule. Consistent with this model, both polyclonal and monoclonal nodules coexist within the same multinodular goiter, the latter presumably having arisen because of the acquisition of a genetic abnormality favoring growth. Not surprisingly, activating mutations affecting proteins of the TSH signaling pathway have been identified in a subset of autonomous thyroid nodules. TSH signaling pathway mutations and their implications in adenomas are discussed later. The follicle hyperplasia and accumulation of colloid produce physical stress that may lead to rupture of follicles and vessels, followed by hemorrhages, scarring, and calcifications. With scarring, nodularity appears, which may be accentuated by the pre-existing stromal framework of the gland. Clinical features. The dominant clinical features of multinodular goiter are those caused by mass effects. In addition to their cosmetic effects, goiters may cause airway obstruction, dysphagia, and compression of large vessels in the neck and upper thorax superior vena cava syndrome. Most patients are euthyroid or have subclinical hyperthyroidism, identified by reduced TSH levels, but about 10% of patients over a 10-year period develop an autonomous nodule within a long-standing goiter that produces hyperthyroidism, toxic multinodular goiter, also known as Plummer syndrome. The incidence of malignancy in long-standing multinodular goiters is low, less than 5%, but not zero, and concern for malignancy arises in goiters that demonstrate sudden changes in size or symptoms, e.g. hoarseness. Dominant nodules in a multinodular goiter can present as a solitary thyroid nodule, mimicking a thyroid neoplasm. A radioiodine scan demonstrates uneven iodine uptake, including the occasional hot autonomous nodule, consistent with an admixture of hyperplastic and involuting nodules. A fine needle aspiration biopsy is helpful, and can often, albeit not always, distinguish between follicular hyperplasia and thyroid neoplasm, see later. Morphology. Multinodular goiters are multilobulated, asymmetrically enlarged glands that can reach weights of more than 2,000 grams. The pattern of enlargement is unpredictable and may involve one lobe far more than the other, producing pressure on midline structures, such as the trachea and esophagus. In other instances, the goiter grows behind the sternum and clavicles to produce the intrathoracic or plunging goiter. Occasionally, most of it is hidden behind the trachea and esophagus. In other instances, one nodule may stand out, mimicking a solitary tumor. On cut section, irregular nodules containing variable amounts of brown gelatinous colloid are present. Figure 24. Older lesions have areas of hemorrhage, fibrosis, calcification, and cystic change. The microscopic appearance includes colloid-rich follicles lined by flattened, inactive epithelium and areas of follicle hyperplasia, accompanied by degenerative changes related to physical stress. In contrast to follicular neoplasms, a prominent capsule between the hyperplastic nodules and residual compressed thyroid parenchyma is not present. Figure 24 is not present in 84. Neoplasms of the thyroid. The solitary thyroid nodule is a palpably discrete swelling within an otherwise apparently normal thyroid gland. The estimated incidence of solitary palpable nodules in the adult population of the United States varies between 1% and 10%, but it is significantly higher in endemic goitrous regions. Single nodules are about 4 times more common in women than in men. The incidence of thyroid nodules increases throughout life. From a clinical standpoint, the major concern in persons who present with thyroid nodules is the possibility of a malignant neoplasm. Fortunately, the overwhelming majority of solitary nodules of the thyroid prove to be localized, non-neoplastic lesions, e.g., a dominant nodule in multinodular goiter, simple cysts, or foci of thyroiditis, or benign neoplasms such as follicular adenoma. In fact, benign neoplasms outnumber thyroid carcinomas by a ratio of nearly 10:1, while only 1% of solitary thyroid nodules are, a B figure, 24.15, multinodular goiter. A. Gross morphology demonstrating a coarsely nodular gland containing areas of fibrosis and cystic change. B. Photomicrograph of a hyperplastic nodule with compressed residual thyroid parenchyma on the periphery. Note the absence of a prominent capsule, a distinguishing feature from follicular neoplasms. B. Courtesy Dr. William Westra, Department of Pathology, Johns Hopkins University, Baltimore, MD. Thyroid gland 1085. Malignant, this still represents about 15,000 new cases of thyroid carcinoma per year in the United States. Fortunately, most of these cancers are indolent. More than 90% of affected patients are alive 20 years after being diagnosed. Several criteria provide clues to the nature of a thyroid nodule. Solitary nodules, nodules in younger patients, and nodules in males are more likely to be neoplastic. A history of radiation treatment to the head and neck region is associated with an increased incidence of thyroid malignancy. Functional nodules that take up radioactive iodine in imaging studies, hot nodules, are much more likely to be benign. These associations and statistics, however, are of little comfort to a patient, in whom the timely recognition of a malignancy can be life-saving. Ultimately, morphologic evaluation of a given thyroid nodule by fine needle aspiration or surgical resection provides the most definitive information about its nature. The following sections consider the major thyroid neoplasms. Thyroid adenomas. Adenomas of the thyroid are typically discrete, solitary masses derived from follicle epithelium, and hence they are also known as follicular adenomas. Clinically, follicular adenomas can be difficult to distinguish from dominant nodules of follicular hyperplasia or from the less common follicular carcinomas. In general, follicular adenomas are not forerunners to carcinomas. Nevertheless, shared genetic alterations raise the possibility that at least a subset of follicular carcinomas arises in pre-existing adenomas. See later. Although the vast majority of adenomas are non-functional, a small minority produces thyroid hormones and causes clinically apparent thyrotoxicosis. Hormone production in functional adenomas, called toxic adenomas, is independent of TSH stimulation. Pathogenesis. Somatic mutations that lead to constitutive activation of the TSH receptor signaling pathway are found in toxic adenomas and toxic multinodular goiter. Gain-of-function mutations, most often in the gene encoding the TSH receptor, THR, and less commonly, the alpha subunit of GS-NAS, cause follicular cells to secrete thyroid hormone independent of TSH stimulation, thyroid autonomy. This leads to hyperthyroidism and produces a functional hot nodule on imaging. Overall, such mutations are present in 50% to 80% of toxic thyroid adenomas. Approximately one-third of toxic adenomas also harbor activating mutations of enhancer of ZST, homolog 1, ESH1, which encodes a histone methyltransferase that functions as an epigenetic regulator of gene expression. Notably, THR, GNAS, and EZH1 mutations are rarely seen in follicular carcinomas. Thus, toxic adenomas and toxic multinodular goiters do not seem to be precancerous lesions. In contrast, a minority 20% to 40% of non-functioning follicular adenomas harbor oncogenic mutations of RAS, and a smaller percentage 5% to 10% express fusion proteins containing the nuclear receptor PAR gamma. Notably, both genetic. Alterations are seen at greater frequencies in follicular carcinomas, suggesting that non-functioning adenomas carrying these alterations are precursors to carcinomas. These are discussed in further detail later in this chapter. Morphology. The typical thyroid adenoma is a solitary, spherical, encapsulated lesion that is demarcated by a well-defined intact capsule, figure 24. By contrast, as the name implies, multinodular goiter contains numerous nodules, even in patients presenting with a solitary dominant nodule. Follicular adenomas average about 3 centimeters in diameter, but some are much larger, greater than or equal to 10 centimeters in diameter. In freshly resected specimens, the adenoma bulges from the cut surface and compresses the adjacent thyroid. The color ranges from gray-white to red-brown, depending on the cellularity of the adenoma and its colloid content. Areas of hemorrhage, fibrosis, calcification, and cystic change, similar to those encountered in multinodular goiters, are common in follicular adenomas, particularly within larger lesions. Microscopically, the constituent cells often form uniform-appearing follicles that contain colloid, figure 24. B. The follicular growth pattern is usually quite distinct from the adjacent non-neoplastic thyroid. The neoplastic cells show little variation in cell size, shape, or nuclear morphology, and mitotic figures are rare. Occasionally, the neoplastic cells acquire brightly eosinophilic granular cytoplasm, oxyphil, or Hürthle cell change, figure 24:17. The hallmark of all follicular adenomas is the presence of an AB figure 24.16 follicular adenoma of the thyroid. A solitary, well-circumscribed nodule is seen. B. The photomicrograph shows well-differentiated follicles resembling normal thyroid parenchyma. Chapter 24. The endocrine system. Figure 24.17. Hürthle cell oxyphil adenoma. A high-power view showing that the tumor is composed of cells with abundant eosinophilic cytoplasm and small regular nuclei. Courtesy Dr. Mary Sunday, Duke University, Durham, NC. Intact, well-formed capsule encircling the tumor. Careful evaluation of the integrity of the capsule is therefore critical in distinguishing follicular adenoma from follicular carcinoma, which demonstrates capsular and/or vascular invasion. See later. Mitotic activity, necrosis, or high cellularity also warrants close inspection to exclude follicular carcinoma and the encapsulated follicular variant of papillary carcinoma. See later. Clinical features many follicular adenomas present as solitary painless masses that are discovered on routine physical examination. Larger masses may produce local symptoms, such as difficulty in swallowing. Non-functioning adenomas take up less radioactive iodine than does normal thyroid parenchyma, and on radionuclide scanning appear as cold nodules. Other techniques used to evaluate suspected adenomas are ultrasonography and fine needle aspiration biopsy. Because of the need for evaluating capsular integrity, the definitive diagnosis of adenoma can be made only after careful histologic examination of the resected specimen. Suspected adenomas of the thyroid are therefore removed surgically to exclude malignancy. Follicular adenomas do not recur or metastasize and have an excellent prognosis. Thyroid carcinomas. It is estimated that there were than 52,000 new cases of thyroid cancer in the United States in 2019, and about 2,000 individuals succumbed to the disease. The rate of newly diagnosed thyroid cancer has been rising dramatically, currently, at the rate of 3% increase in incidence each year in the United States and in countries like South Korea, which has seen a veritable epidemic of thyroid cancer. It is the most common cause of newly diagnosed cancer in women. In contrast to the rising rates of newly diagnosed cancer, mortality from this disease is one of the lowest among solid tumors, with a 5-year survival greater than 98%. The major reason for this good outcome is that many of these cancers are found incidentally during neck palpation or by ultrasonography, and consist of small localized lesions, typically papillary cancers, that have an excellent prognosis. To address this so-called overdiagnosis of thyroid cancer, the nomenclature of a subset of papillary cancers has undergone an important change in the past 2 years. See later. The major subtypes of thyroid carcinoma and their relative frequencies are as follows: papillary thyroid carcinoma PTC, including conventional PTC, and the encapsulated follicular variant, 80% to 80%. This category includes the newly described lesion known as non-invasive follicular thyroid neoplasm with papillary-like nuclear features, a low-grade neoplasm with such a minimal risk of recurrence that carcinoma has been removed from its name. Follicular carcinoma, 10% to 15% of cases, poorly differentiated and anaplastic undifferentiated carcinoma, less than 5% of cases. Medullary carcinoma, 5% of cases. Most thyroid carcinomas are derived from thyroid follicle epithelium, except medullary carcinoma, which is derived from parafollicular C cells, and of these, the vast majority are well-differentiated lesions. In the past decade, with increasing knowledge of the molecular pathology of follicular neoplasms, the concept of multi-step pathogenesis from precursor lesions, which is well established in other epithelial cancers, has gained greater acceptance. In particular, the following 3 precursor lesion relationships have been recognized: papillary microcarcinoma as a precursor to conventional PTC, non-invasive thyroid neoplasma with papillary-like nuclear features as a precursor to invasive encapsulated follicular variant PTC, non-functioning follicular adenoma as a precursor to follicular carcinoma. Further, it is now accepted that most poorly differentiated and anaplastic undifferentiated carcinomas arise from well-differentiated PTC or follicular carcinomas through acquisition of additional mutations. These aggressive neoplasms and medullary thyroid carcinomas are the major causes of mortality from thyroid cancer. We begin with a discussion of the molecular pathogenesis of thyroid neoplasms. Pathogenesis driver mutations. Distinct sets of driver mutations in cancer genes are found in the 4 major histologic variants of thyroid cancer. Among follicular neoplasms, there are both unique and shared genetic alterations between the histologic subtypes, figure 2418, most of which involve components of the receptor tyrosine kinase RTK pathway, which, you will recall, is frequently mutated in many different cancers. Chapter 7. As is also true with other epithelial neoplasms, precursor lesions listed earlier share genetic alterations with the corresponding variant of carcinoma, albeit at a lower frequency. Conventional papillary thyroid carcinomas. Conventional PTCs have 2 defining genetic abnormalities: translocations that result in gene fusions of RET or NTRK, and point mutations in BRAF. See figure 24, 1086. Thyroid gland 1087. Follicular neoplasms. Follicular adenoma, follicular carcinoma NFTP, invasive EFV-PTC, RAS-like PTC-PDTC, and anaplastic carcinoma. Papillary thyroid cancer conventional, BRAF-like PTC, PDTC, and anaplastic carcinoma. Follicular carcinoma, translocation, papillary thyroid cancer conventional. P. BRAF PMEC ERK. GTP-RS, receptor tyrosine kinases RET PTC translocations, NTRK1, NTRK3 fusions, follicular carcinoma PDTC, and anaplastic carcinoma, PI3K. P10P, PDK1, P, AKT, cell growth, proliferation, differentiation, PAX8, PPRG, figure 24.1, 8 genetic alterations in follicle cell-derived neoplasms of the thyroid gland. EFV-PTC, encapsulated follicular variant of papillary thyroid carcinoma, NIFTP, non-invasive follicular thyroid neoplasm with papillary-like nuclear features, PDTC, poorly differentiated thyroid carcinoma. The RET gene is located on chromosome 10q11 and encodes an RTK that is normally not expressed in thyroid follicular cells. As with many other RTKs implicated in cancer, PTC rearrangements involving RET create fusion genes that encode constitutively active forms of RET tyrosine kinase. There are more than 15 fusion partners of RET, and 2, designated PTC1 and PTC2, are most commonly observed in sporadic papillary cancers. Similarly, paracentric inversions or translocations of NTRK1, another gene encoding a receptor tyrosine kinase on chromosome 1q21, are present in approximately 5% of PTCs. These rearrangements also produce constitutively active NTRK1 fusion proteins. Between 50% and 80% of conventional PTCs harbor gain-of-function mutations in the BRAF gene, most commonly a valine to glutamate change in codon 600 BRAF-V600E. BRAF encodes a serine threonine kinase that lies downstream of receptor tyrosine kinases and growth factor signaling pathways. In a subtype of conventional PTCs, known as tall cell variant, see later, BRAF-V600E mutations are virtually a diagnostic sine qua non. The presence of BRAF mutations in conventional PTCs is associated with reduced expression of thyroid differentiation markers, such as thyroglobulin and thyroid peroxidase, and may be associated with a higher risk of extrathyroidal extension and recurrence. As discussed elsewhere, the BRAF-V600E mutation is found in many other cancers, including melanoma and hairy cell leukemia. Chapter 7. Follicular neoplasms. In contrast to papillary carcinomas, follicular neoplasms are often associated with gain-of-function mutations in RAS. Neoplasms with RAS mutations retain expression of thyroid differentiation factors, e.g., thyroglobulin thyroid peroxidase, which may contribute to their follicular growth pattern. Overall, approximately 20% to 40% of follicular adenomas and 30% to 50% of follicular carcinomas harbor RAS mutations. See Figure 20. Similarly, approximately one-half of invasive encapsulated follicular variants of PTC and their putative precursor, non-invasive follicular thyroid neoplasm with papillary-like nuclear features, demonstrate RAS point mutations. A unique 2,3q13p25 translocation has been described in 20% to 50% of follicular carcinomas and approximately 10% of follicular adenomas. This translocation creates a fusion gene composed of portions of PAX8, a paired homeobox gene that is important in thyroid development, and the peroxisome proliferator. Activated receptor gene PARG, which encodes a nuclear hormone receptor implicated in terminal differentiation of thyrocytes. Some non-invasive follicular thyroid neoplasms with papillary-like nuclear features and invasive encapsulated follicular variant of PTC. Up to one-third in some series also harbor PAX8 PARG fusion genes, which are almost never seen in poorly differentiated or anaplastic carcinomas. Finally, up to 10% of follicular carcinomas exhibit gain-of-function mutations of PIK3CA, the gene that encodes phosphoinositide 3 kinase PI3K, or loss-of-function mutations of PTEN, a tumor suppressor gene and negative regulator of this pathway. See Figure 24.18. Poorly differentiated and anaplastic, undifferentiated carcinomas. These highly aggressive and lethal tumors can arise de novo, or much more commonly by dedifferentiation of a papillary or follicular thyroid carcinoma. In addition to driver mutations that are also seen in well-differentiated thyroid cancers, 3 recurrent genetic hits, point mutations of TP53, beta-catenin, CTNNB1, and TERT, which encodes the catalytic component of the enzyme telomerase, are essentially restricted to poorly differentiated and anaplastic carcinomas, and likely have central roles in their genesis and aggressive behavior. Medullary thyroid carcinomas. Familial medullary thyroid carcinomas occur in multiple endocrine neoplasia, type 2, MEN2, see later, and are associated with germline RET mutations that lead to constitutive activation of the receptor. RET mutations are also seen in approximately one-half of non-familial sporadic medullary thyroid cancers. Chromosomal rearrangements involving RET, such as the RET-PTC translocations reported in papillary cancers, are not seen in medullary carcinomas. Environmental factors. The major risk factor predisposing to thyroid cancer is exposure to ionizing radiation, particularly during the first 2 decades of life. In keeping with this, there was a marked increase in the incidence of conventional PTCs among children exposed to ionizing radiation after the Chernobyl nuclear disaster in 1986. Of 1088, Chapter 24, The Endocrine System. Interest: radiation-induced PTCs have a higher frequency of chromosome rearrangements that produce gene fusions, possibly because of the ability of ionizing radiation to induce double-stranded DNA breaks. Deficiency of dietary iodine and, by extension, goiter is associated with a higher frequency of follicular lesions. Papillary carcinoma and follicular variants, including invasive, encapsulated follicular variant of PTC and non-invasive follicular thyroid neoplasm with papillary-like nuclear features, papillary carcinomas are the most common form of thyroid cancer, accounting for nearly 85% of cases in the United States. They occur throughout life, but most often between 25 and 50 years of age, and account for the majority of thyroid carcinomas associated with previous exposure to ionizing radiation. The incidence of papillary carcinoma has increased markedly in the last 30 years, partly because of the rise in detection of papillary microcarcinomas and non-invasive encapsulated variants found incidentally during neck examination. Morphology. Conventional papillary carcinomas may be solitary or multifocal. Some tumors are well circumscribed, while others infiltrate the adjacent parenchyma and have ill-defined margins. The tumors may contain areas of fibrosis and calcification and are often cystic. The cut surface sometimes reveals papillary foci that point to the diagnosis. Papillary microcarcinoma is defined as an otherwise conventional papillary carcinoma, but less than 1 centimeter in size. As stated earlier, they are considered putative precursor lesions of more typical papillary carcinomas. The microscopic hallmarks of papillary neoplasms include the following. Figure 24.19. Branching papillae having a fibrovascular stalk covered by a single to multiple layers of cuboidal epithelial cells. In most neoplasms, the epithelium covering the papillae consists of well-differentiated, uniform, orderly cuboidal cells, but at the other extreme are those with fairly anaplastic epithelium, showing considerable variation in cell and nuclear morphology. When present, the papillae differ from those seen in areas of hyperplasia in being more complex and having dense fibrovascular cores, nuclei with finely dispersed chromatin, and an optically clear or empty appearance, giving rise to the designation ground glass or orphan Annie eye nuclei. In addition, invaginations of the nuclear membrane may give the appearance of nuclear inclusions, pseudo-inclusions, or grooves. The diagnosis of papillary carcinoma can be made based on these nuclear features, even in the absence of papillary architecture. Concentrically calcified structures termed samoma bodies are often present, usually within the cores of papillae. These, a B, C, D figure 24.1. 9. Papillary carcinoma of the thyroid. A. The macroscopic appearance of a papillary carcinoma with grossly discernible papillary structures. B. This particular example contains well-formed papillae. High power shows cells with characteristic empty-appearing nuclei, sometimes called orphan Annie eye nuclei. D. Cells obtained by fine needle aspiration of a papillary carcinoma. Characteristic intranuclear inclusions are visible in some of the aspirated cells. Gland 1089. Structures are almost never found in follicular and medullary carcinomas, and they are a strong indication that the lesion is a papillary carcinoma when present in fine needle aspiration material. Foci of lymphatic invasion by tumor are often present, but involvement of blood vessels is uncommon, particularly in smaller lesions. Metastases to adjacent cervical lymph nodes occur in up to 1/2 of cases. There are over a dozen histologic variants of papillary carcinoma that can mimic other thyroid lesions or harbor distinct prognostic implications. Most are beyond the scope of this book. The tall cell variant has tall columnar cells with intensely eosinophilic cytoplasm. These tumors tend to occur in older individuals and have higher frequencies of vascular invasion, extrathyroidal extension, and cervical and distant metastases than conventional PTC. Tall cell variant papillary carcinomas almost always harbor BRAF mutations and often have RET PTC translocations as well. The co-occurrence of these two aberrations may contribute to the aggressive behavior of this variant. An unusual diffuse sclerosing variant of papillary carcinoma occurs in younger individuals, including children. The tumor has a prominent papillary growth pattern intermixed with solid areas containing nests of squamous metaplasia. As the name suggests, there is extensive diffuse fibrosis throughout the thyroid gland, often associated with a prominent lymphocytic infiltrate, simulating Hashimoto thyroiditis. Lymph node metastases are present in almost all cases. The diffuse sclerosing variant carcinomas lack BRAF mutations, but RET TPC translocations are found in approximately 1/2 of cases. The follicular variant of PTC has the characteristic nuclear features of papillary carcinoma and an almost totally follicular architecture. As mentioned earlier, genetic analyses have shown that encapsulated follicular variants of PTC harbor distinct molecular abnormalities from conventional PTCs. As already discussed, encapsulated follicular variants of papillary thyroid cancer without capsular invasion are designated non-invasive follicular thyroid carcinoma with papillary-like nuclear features and have a very low risk of recurrence or metastasis, whereas invasive tumors are referred to as invasive encapsulated follicular variant of papillary thyroid carcinoma. Clinical features: most conventional papillary carcinomas present as asymptomatic thyroid nodules, but the first manifestation may be a mass in a cervical lymph node. Interestingly, the presence of isolated cervical nodal metastases does not have a significant impact on prognosis, which is generally good. Most carcinomas are single nodules that move freely with the thyroid gland during swallowing and are not distinguishable on examination from benign nodules. Hoarseness, dysphagia, cough, or dyspnea suggests advanced disease. In a minority of patients, hematogenous metastases are present at the time of diagnosis, most commonly in the lung. A variety of diagnostic tests have been used to help separate benign from malignant thyroid nodules, including radionuclide scanning and fine needle aspiration. Papillary carcinomas are cold masses on scintigraphy. Improvements in cytologic analysis have made fine needle aspiration cytology a reliable test for distinguishing between benign and malignant nodules. Papillary thyroid cancers have an excellent prognosis, with a 10-year survival rate in excess of 95%. Patients with papillary microcarcinomas and non-invasive follicular thyroid neoplasms with papillary-like nuclear features have an outstanding prognosis on lobectomy alone, and they typically do not require total thyroidectomy. This has become especially important since thyroidectomy may lead to vocal cord palsy due to injury to the laryngeal nerve and iatrogenic hypoparathyroidism. Between 5% and 20% of patients with more typical PTCs have local or regional recurrences, and 10% to 15% have distant metastases. The prognosis is dependent on several factors, including age in general being less favorable among patients older than 40 years, presence of extrathyroidal extension, and presence of distant metastases stage. Follicular carcinoma. Follicular carcinoma accounts for 5% to 15% of primary thyroid cancers. It is more frequent in areas with dietary iodine deficiency, where it constitutes 25% to 40% of thyroid cancers. It is more common in women 3-1 and presents more often in older patients than does papillary carcinoma. The peak incidence is between 40 and 60 years of age. Morphology: follicular carcinomas are single nodules that may be well circumscribed or widely infiltrative. Figure 2420A. Sharply demarcated lesions may be exceedingly difficult to distinguish from follicular adenomas by gross examination. Larger lesions may penetrate the capsule and infiltrate into the adjacent neck. They are gray to tan to pink on cut section and may be translucent due to the presence of large colloid-filled follicles. Degenerative changes such as central fibrosis and foci of calcification may be present. Microscopically, most follicular carcinomas are composed of fairly uniform cells forming small follicles containing colloid, quite reminiscent of normal thyroid, figure 24. In other cases, follicular differentiation may be less apparent, and there may be nests or sheets of cells without colloid. Occasional tumors are dominated by cells with abundant granular, eosinophilic cytoplasm, Hürthl cell, or oncocytic variant of follicular carcinoma. Whatever the pattern, the nuclei lack the features typical of papillary carcinoma, and psammoma bodies are not present. There is no reliable cytologic difference between follicular adenomas and minimally invasive follicular carcinomas. Making this distinction requires extensive histologic sampling of the tumor capsule to exclude capsular and/or vascular invasion. Figure 24. The criterion for vascular invasion is applicable only to capsular vessels and vascular spaces. Beyond the capsule, the presence of tumor plugs within intratumoral blood vessels has little prognostic significance. Unlike in papillary cancers, lymphatic spread is uncommon in follicular cancers. By contrast, the diagnosis of carcinoma is obvious in widely invasive follicular carcinomas, which infiltrate the thyroid parenchyma and extrathyroidal soft tissues. Histologically, these cancers tend to have a greater proportion of solid or trabecular growth pattern, less evidence of follicular differentiation, and increased mitotic activity. Thyroid. 1090, Chapter 24, the Endocrine System, A, B Figure 24.2, 1 Capsular integrity in follicular neoplasms. In adenomas, a fibrous capsule, usually thin but occasionally more prominent, circumferentially surrounds the neoplastic follicles, and no capsular invasion is seen. Compressed, normal thyroid parenchyma is usually present. B. A few of the glandular lumens contain recognizable colloid, external to the capsule top of panel. In contrast, follicular carcinomas demonstrate capsular invasion B that may be minimal, as in this case, or widespread. The presence of vascular invasion is another feature of follicular carcinomas. Figure 24.20 Follicular carcinoma. Cut surface of a follicular carcinoma with substantial replacement of the lobe of the thyroid. The tumor has a light tan appearance and contains small foci of hemorrhage. Clinical features: follicular carcinomas present as slowly enlarging painless nodules. Most frequently, they are cold nodules on scintigrams, although rare, better differentiated lesions may be hyperfunctional, take up radioactive iodine, and appear warm on scintigraphy. Because follicular carcinomas have little propensity for invading lymphatics, regional lymph nodes are typically not involved, while vascular hematogenous dissemination is common, with metastases to bone, lungs, liver, and elsewhere. The prognosis depends largely on the extent of invasion and stage at presentation. Widely invasive follicular carcinoma often presents with systemic metastases, and as many as 1/2 of affected patients succumb to their disease within 10 years. This is in sharp contrast to minimally invasive follicular carcinomas, which have a 10-year survival rate of greater than 90%. Most follicular carcinomas are treated with total thyroidectomy followed by the administration of radioactive iodine, which can be used to identify metastases and to ablate such lesions. In addition, because any residual follicular carcinoma may respond to TSH stimulation, patients are usually treated with thyroid hormone after surgery to suppress endogenous TSH levels. Serum thyroglobulin levels are used for monitoring tumor recurrence, because this thyroid protein should be barely detectable in a patient who is free of disease. Poorly differentiated and anaplastic undifferentiated carcinoma. Poorly differentiated and anaplastic undifferentiated carcinomas represent aggressive neoplasms of the thyroid follicular epithelium, cumulatively accounting for less than 5% of thyroid tumors, but with a high mortality rate, approaching 100% for anaplastic lesions. Patients with either carcinoma are older than those with other types of thyroid cancer, with a mean age of 65 years, approximately. Thyroid gland 1091. 1/4 of patients with poorly differentiated or anaplastic thyroid carcinomas have a past history of a well-differentiated follicular neoplasm, and another 1/4 harbor a concurrent well-differentiated neoplasm in the resected specimen. Morphology. Microscopically, poorly differentiated carcinomas are composed of cells with minimal follicular differentiation. Arranged in insular or trabecular growth patterns, intratumoral necrosis and frequent mitosis are often seen. Anaplastic carcinomas demonstrate variable morphology, including 1 large pleomorphic giant cells, including occasional osteoclast-like multinucleate giant cells, 2 spindle cells with a sarcomatous appearance, and 3 mixed spindle and giant cells. Foci of papillary or follicular differentiation may be present in some tumors, suggesting an origin from a well-differentiated carcinoma. The neoplastic cells express epithelial markers like cytokeratin, but are usually negative for markers of thyroid differentiation like thyroglobulin. Morphology: sporadic medullary thyroid carcinomas present as a solitary nodule, figure 2422A. In contrast, bilaterality and multicentricity are common in familial cases. Larger lesions often contain areas of necrosis and hemorrhage, and may extend through the capsule of the thyroid. The tumors are firm, pale gray to tan, and infiltrative. There may be foci of hemorrhage and necrosis in larger lesions. Microscopically, medullary carcinomas are composed of polygonal to spindle-shaped cells which may form nests, trabeculae, and even follicles. Small, more anaplastic cells are present in some tumors and may be the predominant cell type. Amyloid deposits, derived from calcitonin polypeptides, are present in the stroma in many cases, figure 2422B. Calcitonin is readily demonstrable within the cytoplasm of the tumor cells, as well as in the stromal amyloid by immunohistochemical methods. As with all neuroendocrine tumors, electron microscopy reveals variable numbers of membrane-bound electron-dense granules within the cytoplasm of the neoplastic cells, figure 2423. One of the features of familial clinical features: poorly differentiated and anaplastic carcinomas usually present as rapidly enlarging bulky neck masses. In most cases, the disease has spread beyond the thyroid into adjacent neck structures or has metastasized to the lungs at the time of presentation. Symptoms related to compression and invasion of adjacent structures, such as dyspnea, dysphagia, hoarseness, and cough, are common. Anaplastic carcinomas of the thyroid are one of the most aggressive cancers known. In most cases, death occurs in less than 1 year. Poorly differentiated carcinomas fare somewhat better with radical surgery, external beam radiotherapy, and radioactive iodine. More recently, immunotherapy using immune checkpoint inhibitors has been used in these neoplasms in an attempt to improve their dire prognosis. Medullary carcinoma. Medullary carcinomas of the thyroid are neuroendocrine neoplasms, derived from the parafollicular cells, C cells. They account for approximately 5% of thyroid neoplasms. Medullary carcinomas, like normal C cells, secrete calcitonin, the measurement of which plays an important role in the diagnosis and postoperative follow-up of patients. Calcitonin is a regulator of calcium metabolism. It is normally produced in response to hypercalcemia, and it reduces serum calcium by inhibiting osteoclast activity and renal tubular reabsorption of calcium. In some instances, the tumor cells elaborate other polypeptide hormones, such as serotonin, ACTH, and vasoactive intestinal peptide VIP. About 70% of tumors arise sporadically. The remainder occur in the setting of MEN2A, or MEN 2 billion syndromes. Recall that activating point mutations in the RET proto-oncogene play an important role in the development of both familial and sporadic medullary carcinomas. Cases associated with MEN2A or MEN2B occur in younger patients, and they may even arise during the first decade of life. In contrast, sporadic and familial medullary carcinomas are neoplasms of adulthood, with a peak incidence in the 40 seconds and 50 seconds. B. Figure 24.2, medullary carcinoma of the thyroid. These tumors typically show a solid pattern of growth and do not have connective tissue capsules. B. Histology demonstrates abundant deposition of amyloid, visible here as homogeneous, extracellular material, derived from calcitonin secreted by the neoplastic cells. Courtesy Dr. Joseph Corson, Brigham and Women's Hospital, Boston, Mass. 1092 Chapter 24 The Endocrine System, and have shown considerable promise in clinical trials of patients with medullary carcinoma. Medullary. Figure 24.23 Electron micrograph of medullary thyroid carcinoma. These cells contain membrane-bound secretory granules that are the sites of storage of calcitonin and other peptides. Cancers is the presence of multicentric C-cell hyperplasia in the surrounding thyroid parenchyma, a feature that is usually absent in sporadic lesions, and that is believed to be a precursor lesion in familial cases. Thus, the presence of multiple prominent clusters of C-cells scattered throughout the parenchyma should raise the specter of an inherited predisposition, even if a family history is not present. Clinical features sporadic cases of medullary carcinoma come to medical attention most often as a mass in the neck, sometimes associated with dysphagia or hoarseness. In some instances, the initial manifestations are those of a paraneoplastic syndrome caused by the secretion of a peptide hormone, e.g. diarrhea due to the secretion of very important person, or Cushing's syndrome due to ACH. Notably, hypocalcemia is not a prominent feature, despite the presence of raised calcitonin levels. In addition to circulating calcitonin, secretion of carcinoembryonic antigen by the neoplastic cells is a useful biomarker, especially for presurgical assessment of tumor load and in calcitonin-negative tumors. Patients with familial syndromes may come to attention because of symptoms localized to the thyroid, or as a result of endocrine neoplasms in other organs, e.g. adrenal or parathyroid glands. Medullary carcinomas arising in the context of MEN 2 billions are generally more aggressive and metastasize more frequently than those occurring in patients with sporadic tumors or MEN 2A. As discussed later, asymptomatic MEN-2 individuals carrying germline RET mutations are offered prophylactic thyroidectomy as early as possible to prevent the otherwise inevitable development of medullary carcinoma, the major risk factor for poor outcome in these individuals. Sometimes the only histologic finding in the resected thyroid of asymptomatic carriers is the presence of C-cell hyperplasia or small, less than 1 centimeter micromedullary carcinomas. Several small molecule inhibitors of RET tyrosine kinase have recently been developed. Key concepts: thyroid neoplasms. Most thyroid neoplasms manifest as solitary thyroid nodules. Only 1% of all thyroid nodules are neoplastic. Multiple genetic pathways are involved in thyroid carcinogenesis. Conventional papillary carcinomas harbor either fusions RET, PTC, NTRK, or BRAF point mutations. Follicular neoplasms of all subtypes are characterized by oncogenic RAS mutations and PAX8 PARG fusions. Progression to aggressive neoplasms is associated with TP53, CTNNB1, and TERT mutations. Follicular adenomas and carcinomas both are composed of well-differentiated follicular epithelial cells. The latter are distinguished by evidence of capsular and/or vascular invasion. Conventional papillary carcinomas are recognized based on nuclear features, ground glass nuclei, pseudo-inclusions even, in the absence of papillae. Semoma bodies are a characteristic feature of papillary cancers. These neoplasms often metastasize by way of lymphatics, but the prognosis is excellent. Encapsulated variants of papillary carcinoma without capsular or lymphatic invasion have recently been named non-invasive follicular thyroid neoplasm with papillary-like nuclear features to emphasize their ultra-low risk potential for metastasis or recurrence. Poorly differentiated and anaplastic carcinomas are thought to arise from more differentiated thyroid carcinomas. They are highly aggressive, often lethal cancers. Medullary cancers are neoplasms arising from parafollicular C cells and can occur in either sporadic 70% or familial 30%. Settings: multicentricity and C-cell hyperplasia are features of familial cases. Amyloid deposits are a characteristic histologic finding. Congenital anomalies. Thyroglossal duct cyst is the most common clinically significant congenital anomaly of the thyroid. A sinus tract may persist as a vestige of the tubular development of the thyroid gland. Parts of this tube may be obliterated, leaving small segments that form cysts. These occur at any age and might not become evident until adult life. Mucinous clear secretions may collect within the cysts to form either spherical masses or fusiform swellings, rarely over 2 to 3 centimeters in diameter, that present in the midline of the neck anterior to the trachea. Segments of the duct and cysts that occur high in the neck are lined by stratified squamous epithelium, resembling the covering of the posterior portion of the tongue in the region of the foramen cecum. Anomalies that occur in the lower neck, more proximal to the thyroid gland, are lined by epithelium, resembling the thyroidal acinar epithelium. Characteristically, subjacent to the lining epithelium, there is an intense lymphocytic infiltrate. Superimposed infection may convert these lesions into abscess cavities, and rarely they give rise to cancers. Parathyroid glands 1093. Parathyroid glands. The parathyroid glands are derived developmentally from pharyngeal pouches that also give rise to the thymus. They are most commonly located in close proximity to the upper and lower poles of each thyroid lobe, but may be found anywhere along the pathway of descent of the pharyngeal pouches, including the carotid sheath, the thymus, and elsewhere in the anterior mediastinum. The 4 parathyroid glands are composed of 2 cell types, chief cells and oxyphil cells. Chief cells predominate. They are polygonal, 12 to 20 micrometers in diameter, and have central, round, uniform nuclei and light to dark pink cytoplasm. Chief cells have secretory granules containing parathyroid hormone PTH. Oxyphil cells and transitional oxyphils are found throughout the normal parathyroid, either singly or in small clusters. They are slightly larger than the chief cells, have acidophilic cytoplasm, and are tightly packed with mitochondria. Glycogen granules are also present in these cells, but secretory granules are sparse or absent. In early infancy and childhood, the parathyroid glands are composed almost entirely of solid sheets of chief cells. The amount of stromal fat increases up to 25 years of age, reaching a maximum of approximately 30% of the gland, and then plateaus. The function of the parathyroid glands is to regulate calcium homeostasis. The activity of the parathyroid glands is controlled by the level of free ionized calcium in the blood. Normally, decreased levels of free calcium stimulate the synthesis and secretion of PTH. Several metabolic functions of PTH regulate serum calcium levels. Increased renal tubular reabsorption of calcium, thereby conserving free calcium. Increased conversion of vitamin D to its active dihydroxy form in the kidneys, which, in turn, augments gastrointestinal calcium absorption. Increased urinary phosphate excretion, thereby lowering serum phosphate levels and further increasing calcium since phosphate binds to ionized calcium. Enhanced osteoclastic activity, i.e. bone resorption, thus releasing ionized calcium by promoting the differentiation of osteoclast progenitor cells into mature osteoclasts. The net result of these activities is to elevate the level of free calcium, which in turn inhibits further PTH secretion in a classic feedback loop. Similar to the other endocrine organs, abnormalities of the parathyroid glands include both hyperfunction and hypofunction. Tumors of the parathyroid glands, in contrast to thyroid tumors, usually come to attention because of excessive secretion of PTH rather than mass effects. Secondary hyperparathyroidism, compensatory hypersecretion of PTH in response to prolonged hypocalcemia, most commonly from chronic renal failure. Tertiary hyperparathyroidism, persistent hypersecretion of PTH, even after the cause of prolonged hypocalcemia is corrected, e.g. after renal transplant. Primary hyperparathyroidism. Primary hyperparathyroidism is one of the most common endocrine disorders, and it is an important cause of hypercalcemia. The frequency of the various parathyroid lesions underlying hyperfunction is as follows. Adenoma, 85% to 95%. Primary hyperplasia, diffuse or nodular, 5% to 10%. Parathyroid carcinoma, approximately 1%. Primary hyperparathyroidism is usually a disease of adults and is more common in women than in men by a ratio of nearly 4:1. The annual incidence is now estimated to be about 25 cases per 100,000 in the United States and Europe. As many as 80% of patients with this condition are identified in the outpatient setting when hypercalcemia is discovered incidentally on a serum electrolyte panel. Most cases occur in the 50 seconds or later in life. The most common cause of primary hyperparathyroidism is a solitary sporadic parathyroid adenoma. Figure 20. Most, if not all, sporadic parathyroid adenomas are monoclonal, consistent with a neoplastic origin. As with nodules and goitrous thyroids, sporadic parathyroid hyperplasia is also monoclonal in many instances, particularly when associated with a persistent stimulus for parathyroid growth. Refractory secondary or tertiary parathyroidism. See later, suggesting that these lesions lie in the gray zone between reactive hyperplasia and neoplasia. There are 2 molecular. Hyperparathyroidism. Hyperparathyroidism is caused by elevated PTH and is classified into primary, secondary, and tertiary types. Primary hyperparathyroidism, an autonomous overproduction of PTH, usually resulting from an adenoma or hyperplasia of parathyroid tissue. Figure 24.2, for parathyroid adenoma imaging. Technetium 99 meters sestami B radionuclide scan demonstrates an area of increased uptake corresponding to the left inferior parathyroid gland, arrow, which contained a parathyroid adenoma. Preoperative scintigraphy is useful in localizing and distinguishing adenomas from parathyroid hyperplasia, where more than one gland demonstrates increased uptake. 1094, Chapter 24, the endocrine system. Defects that have an established role in the development of sporadic adenomas. Cyclin D1 CCDN1 gene inversions, leading to overexpression of cyclin D1 protein, a major regulator of the cell cycle. A paracentromeric inversion on chromosome 11 results in relocation of CCDN1, normally on 11q, so that it is positioned adjacent to the 5-flanking region of the PTH gene on 11p. As a consequence of these changes, a 5 regulatory element flanking the PTH gene directs overexpression of cyclin D1, causing the cells to proliferate. Between 10% and 20% of sporadic parathyroid adenomas have this clonal rearrangement. In addition, cyclin D1 is overexpressed in approximately 40% of parathyroid adenomas, suggesting that mechanisms other than CCDN1 gene inversion can lead to its overexpression. MEN1 mutations, approximately 30% to 35% of sporadic parathyroid tumors have somatic mutations of the MEN1 gene, a tumor suppressor gene on chromosome 11q13, with loss of heterozygosity low of the second allele. Germline mutations of MEN1 are also found in patients with familial parathyroid adenomas. See later. The spectrum of MEN1 mutations in sporadic tumors is virtually identical to that in familial parathyroid adenomas. In addition, CDC73, which encodes a protein known as parafibromin, is mutated in approximately 70% of sporadic parathyroid carcinomas, but rarely in adenomas. Germline mutations of CDC73 lead to a rare syndrome known as hyperparathyroidism, jaw tumor syndrome, which includes parathyroid carcinomas and ossifying jaw tumors as part of the disease spectrum. Familial syndromes are a distant second to sporadic parathyroid adenomas as causes of primary hyperparathyroidism. The genetic syndromes associated with familial parathyroid adenomas include MEN1, MEN2, and MEN4, discussed in further detail later, as well as familial hypocalciuric hypercalcemia, a rare autosomal dominant disorder caused by loss of function mutations in the parathyroid calcium-sensing receptor (CASR) gene, which results in decreased sensitivity to extracellular calcium. Morphology. The morphologic changes seen in primary hyperparathyroidism involve the parathyroid glands and organs that are affected by elevated levels of PTH and calcium. Parathyroid adenomas are almost always solitary, and like normal parathyroid glands, may be in close proximity to the thyroid or in an ectopic site, e.g. the mediastinum. The typical adenoma averages 0.5 to 5 grams and consists of a well-circumscribed, soft tan to reddish-brown nodule invested by a delicate capsule. In contrast to primary hyperplasia, the glands outside the adenoma are usually normal in size or shrunken because of feedback inhibition by elevated levels of serum calcium. Microscopically, parathyroid adenomas are mostly composed of uniform, polygonal chief cells with small, centrally placed nuclei figure 24, 25. At least a few nests of larger oxyphil cells are present as well. Uncommonly, adenomas are composed entirely of this cell type, oxyphil adenomas. These may resemble Hürthle cell tumors in the thyroid, a rim of compressed, non-neoplastic parathyroid tissue, generally separated by a fibrous, AB, figure 24.25 parathyroid adenoma. A. Solitary chief cell parathyroid adenoma, low-power photomicrograph, revealing delineation from the residual gland below. B. High-power detail of a chief cell parathyroid adenoma. There is slight variation in nuclear size but no anaplasia and a tendency for follicle formation. Capsule is often visible at the edge of the adenoma. Mitotic figures are rare, but it is not uncommon to find bizarre and pleomorphic nuclei, even within adenomas, so-called endocrine atypia. This is not a criterion for malignancy. In contrast to the normal parathyroid parenchyma, adipose tissue is inconspicuous. Primary hyperplasia may occur sporadically or as a component of MEN syndrome. Although classically all 4 glands are involved, there is frequently asymmetry with apparent sparing of 1 or 2 glands, making the distinction between hyperplasia and adenoma difficult. The combined weight of all glands rarely exceeds 1 gram and is often less. Microscopically, the most common pattern seen is that of chief cell hyperplasia, which may involve the glands in a diffuse or multinodular pattern. Less commonly, the constituent cells contain abundant glycogen, giving them a clear appearance in histologic sections, water-clear cell hyperplasia. In many instances, there are islands of oxyphils and poorly developed delicate fibrous strands may envelop the nodules. As in the case of adenomas, stromal fat is inconspicuous within hyperplastic glands. Parathyroid carcinomas may be circumscribed lesions that are difficult to distinguish from adenomas, or they may be clearly invasive neoplasms. These tumors enlarge one parathyroid gland and consist of gray-white irregular masses that sometimes exceed 10 grams in weight. The cells are usually uniform and resemble normal parathyroid cells, and are arrayed in nodular or trabecular patterns. Parathyroid glands 1095. The mass is usually enclosed by a dense, fibrous capsule. Diagnosis of carcinoma based on cytologic detail is unreliable, and invasion of surrounding tissues and metastases are the only reliable criteria. Local recurrence occurs in 1/3 of cases, and more distant dissemination occurs in another third. Morphologic changes of hyperparathyroidism in the skeletal system, chapter 26, and the urinary tract deserve special mention. Symptomatic, untreated primary hyperparathyroidism manifests with 3 interrelated skeletal abnormalities: osteoporosis, brown tumors, and osteitis fibrosa cystica. The osteoporosis results in decreased bone mass with preferential involvement of the phalanges, vertebrae, and proximal femur. For unknown reasons, the increased osteoclast activity in hyperparathyroidism affects cortical bone, superiosteal, and endosteal surfaces more severely than medullary bone. In medullary bone, osteoclasts tunnel centrally along the length of the trabeculae, creating the appearance of railroad tracks and producing what is known as dissecting osteitis fig to dissecting os6. The marrow spaces around the affected surfaces are replaced by fibrovascular tissue. The bone loss predisposes to microfractures and secondary hemorrhages that elicit an influx of macrophages and an ingrowth of reparative, fibrous tissue, creating a mass of reactive tissue known as a brown tumor. See figure 26:13, chapter 26. The brown color is the result of the vascularity, hemorrhage, and hemosiderin deposition, and it is not uncommon for the lesions to undergo cystic degeneration. The combination of increased osteoclast activity, paratrabecular fibrosis, and cystic brown tumors is the hallmark of severe hyperparathyroidism and is known as generalized osteitis fibrosa cystica von Recklinghausen disease of bone. Osteitis fibrosa cystica is now rarely encountered because hyperparathyroidism is usually diagnosed on routine blood tests and treated at an early asymptomatic stage. See later. PTH-induced hypercalcemia favors formation of urinary tract stones, nephrolithiasis, as well as calcification of the renal, interstitium, and tubules. Nephrocalcinosis. Metastatic calcification, secondary to hypercalcemia, may also be seen in other sites, including the stomach, lungs, myocardium, and blood vessels. Clinical features: primary hyperparathyroidism may be 1, asymptomatic and identified on routine blood chemistry profile, or 2, associated with the classic clinical manifestations of primary hyperparathyroidism. Asymptomatic hyperparathyroidism Because serum calcium levels are routinely assessed, most patients with primary hyperparathyroidism are diagnosed incidentally. In fact, primary hyperparathyroidism is the most common cause of asymptomatic hypercalcemia. Hence, many of the classic manifestations, particularly those referable to bone and renal disease, are now seen infrequently in clinical practice. Among other causes of hypercalcemia, Table 24.5, malignancy stands out as the most frequent cause of symptomatic hypercalcemia in adults and must be excluded by appropriate clinical and laboratory investigations. As discussed in Chapter 7, hypercalcemia can occur with solid tumors, such as lung, breast, head and neck, and renal cancers, and with hematologic malignancies, notably multiple myeloma. The most common mechanism in approximately 80% of cases through which osteolytic tumors induce hypercalcemia is by secretion of PTH-related peptide, PSRP, which, like PTH, induces osteoclastic bone resorption and hypercalcemia. The remaining 20% induce hypercalcemia through metastases to the bone and subsequent cytokine-induced bone resorption. In individuals with primary hyperparathyroidism, serum PTH levels are inappropriately elevated for the level of serum calcium, whereas PTH levels are low to undetectable in hypercalcemia caused by non-parathyroid diseases. See Table 24.5. Radioimmunoassays specific for PTH and PARP are available and can be useful in distinguishing primary hyperparathyroidism and malignancy-associated hypercalcemia. Other laboratory alterations referable to PTH excess include hypophosphatemia and increased urinary excretion of both calcium and phosphate. Secondary renal disease may in turn lead to phosphate retention, normalizing the serum phosphate levels. Symptomatic primary hyperparathyroidism. The signs and symptoms of hyperparathyroidism reflect the combined effects of increased PTH secretion and hypercalcemia. Primary hyperparathyroidism is associated with painful bones, renal stones, abdominal groans, and psychic moans. The constellation of symptoms includes the following. Table 245. Of hypercalcemia. Increased PTH, decreased PTH. Hyperparathyroidism. Hypercalcemia of malignantia. Primary, adenoma, greater than hyperplasia of vitamin D toxicity. Secondary immobilization, tertiary thiazide diuretics. Familial hypocalciuric hypercalcemia granulomatous disease. Sarcoidosis, PTH, parathyroid hormone. Primary hyperparathyroidism is the most common cause of hypercalcemia overall. Malignancy is the most common cause of symptomatic hypercalcemia. Primary hyperparathyroidism and malignancy account for nearly 90% of cases of hypercalcemia. Secondary and tertiary hyperparathyroidism are most commonly associated with progressive renal failure. Causes. Figure 24.2. Hyperparathyroidism, with osteoclasts boring into the center of the trabeculum, dissecting osteitis. Photomicrograph reproduced from Horvath A. Bone and Soft Tissue Pathology, a volume in the High-Yield Pathology Series, Philadelphia, 2012, Elsevier. Chapter 24, The Endocrine System, Bone Disease, and Bone Pain. Secondary to fractures of bones weakened by osteoporosis or osteitis fibrosa cystica, nephrolithiasis, renal stones, in 20% of newly diagnosed patients with attendant pain and obstructive uropathy. Chronic renal insufficiency and abnormalities in renal function lead to polyuria and secondary polydipsia. Gastrointestinal disturbances, including constipation, nausea, peptic ulcers, pancreatitis, and gallstones. Central nervous system alterations, including depression, lethargy, and eventually seizures. Neuromuscular abnormalities, including weakness and fatigue. Cardiac manifestations, including aortic or mitral valve calcifications, or both. The abnormalities most directly related to hyperparathyroidism are nephrolithiasis and bone disease, whereas those attributable to hypercalcemia include fatigue, weakness, pancreatitis, metastatic calcifications, and constipation. Secondary hyperparathyroidism. Secondary hyperparathyroidism is caused by any condition that gives rise to chronic hypocalcemia, which, in turn, leads to compensatory overactivity of the parathyroid glands. Renal failure is by far the most common cause of secondary hyperparathyroidism, although several other diseases, including inadequate dietary intake of calcium, steatorrhea, and vitamin D deficiency, may also cause this disorder. The mechanisms by which chronic renal failure induces secondary hyperparathyroidism are complex and not fully understood. Chronic renal insufficiency is associated with decreased phosphate excretion, which, in turn, results in hyperphosphatemia. The elevated serum phosphate levels directly depress serum calcium levels and thereby stimulate parathyroid gland activity. In addition, loss of renal substance reduces the availability of alpha-1 hydroxylase, which is necessary for the synthesis of the active form of vitamin D, leading in turn to reduced intestinal absorption of calcium. Chapter 9. Because vitamin D has suppressive effects on parathyroid growth and PTH secretion, its deficiency compounds the hyperparathyroidism and renal failure. Morphology. The parathyroid glands in secondary hyperparathyroidism are hyperplastic. As in primary hyperparathyroidism, the degree of glandular enlargement may be asymmetric. Microscopically, the hyperplastic glands contain an increased number of chief cells, or water-clear cells, in a diffuse or multinodular distribution. Fat cells are decreased in number. Metastatic calcification may be seen in many tissues, including the lungs, heart, stomach, and blood vessels. Clinical features. The clinical features of secondary hyperparathyroidism are usually dominated by the inciting chronic renal failure. Secondary hyperparathyroidism is usually not as severe or as prolonged as primary hyperparathyroidism, hence the skeletal abnormalities referred to as renal osteodystrophy tend to be milder. Control of the hyperparathyroidism allows the bony changes to regress significantly or disappear completely. The vascular calcification associated with secondary hyperparathyroidism may occasionally result in significant ischemic damage to skin and other organs. a process referred to as calciphylaxis. Patients with secondary hyperparathyroidism often respond to dietary vitamin D supplementation as well as phosphate binders, which decrease the prevailing hyperphosphatemia. In a minority of patients, parathyroid activity may become autonomous and excessive, with resultant hypercalcemia, a process termed tertiary hyperparathyroidism. Parathyroidectomy may be necessary to control the hyperparathyroidism in such patients. Key concepts. Hyperparathyroidism. Primary hyperparathyroidism is the most common cause of asymptomatic hypercalcemia. In a majority of cases, primary hyperparathyroidism is caused by a sporadic parathyroid adenoma and, less commonly, by parathyroid hyperplasia. Parathyroid adenomas are solitary, while hyperplasia typically is a multiglandular process. Skeletal manifestations of hyperparathyroidism include bone, resorption, osteitis fibrosis cystica, and brown tumors. Renal changes include nephrolithiasis, stones, and nephrocalcinosis. The clinical manifestations of hyperparathyroidism have been classically summarized as painful bones, renal stones, abdominal groans, and psychic moans. Secondary hyperparathyroidism most often is caused by renal failure, which lowers serum calcium levels, resulting in reactive hyperplasia of parathyroid glands. Malignancies are the most important cause of symptomatic hypercalcemia, which results from osteolytic metastases or release of PTH-related protein from non-parathyroid tumors. Hypoparathyroidism. Hypoparathyroidism is far less common than is hyperparathyroidism. Acquired hypoparathyroidism is almost always an inadvertent consequence of surgery. In addition, there are several genetic causes of hypoparathyroidism. Surgically induced hypoparathyroidism occurs with inadvertent removal of all parathyroid glands during thyroidectomy, excision of parathyroid glands, in the mistaken belief that they are lymph nodes during radical neck dissection for some form of malignant disease, or removal of too large a proportion of parathyroid tissue in the treatment of primary hyperparathyroidism. Autoimmune hypoparathyroidism is often associated with chronic mucocutaneous candidiasis and primary adrenal insufficiency. This syndrome is known as APS1 and is caused by mutations in the autoimmune regulator AIR gene. The syndrome typically presents in childhood with the onset of candidiasis, followed several years later by hypoparathyroidism and then adrenal insufficiency during adolescence. APS1 is discussed further later in this chapter. Endocrine pancreas 1097. Autosomal dominant hypoparathyroidism is caused by gain of function mutations in the calcium sensing receptor CASR gene. Inappropriate CASR activity due to heightened calcium sensing suppresses PTH, resulting in hypocalcemia and hypercalciuria. Recall that loss of function CASR mutations are a rare cause of familial parathyroid adenomas. Familial isolated hypoparathyroidism FIH is a rare condition with either autosomal dominant or autosomal recessive patterns of inheritance. Autosomal dominant FIH is caused by a mutation in the gene encoding PTH that impairs PTH processing to the mature active hormone. Autosomal recessive FIH is caused by loss of function mutations in the transcription factor gene GCM2, which is essential for development of the parathyroid. Congenital absence of parathyroid glands can occur in conjunction with other malformations, such as thymic and cardiovascular defects, or as a component of the 22q11 deletion syndrome. As discussed in Chapter 6, when thymic defects are present, the condition is called DeGeorge syndrome. Clinical features. The major manifestations of hypoparathyroidism are related to the severity and chronicity of the hypocalcemia. The hallmark of hypocalcemia is tetany, which is characterized by neuromuscular irritability, resulting from decreased serum calcium levels. The symptoms range from circumoral numbness or paresthesias, tingling of the distal extremities and carpopedal spasm, to life-threatening laryngospasm and generalized seizures. The classic findings on physical examination are Chvostek sign and Trousseau sign. Chvostek sign is elicited in subclinical disease by tapping along the course of the facial nerve, which induces contractions of the muscles of the eye, mouth, or nose. Trousseau sign refers to carpal spasms produced by occlusion of the circulation to the distal arm with a blood pressure cuff for several minutes. Mental status changes include emotional instability, anxiety and depression, confusional states, hallucinations, and frank psychosis. Intracranial manifestations include calcifications of the basal ganglia, Parkinsonian-like movement disorders, and increased intracranial pressure with resultant papilledema. The paradoxical association of hypocalcemia with calcifications may be because of an increase in phosphate levels, leading to deposition of calcium phosphate in vulnerable tissues. Ocular disease takes the form of calcification of the lens and cataract formation. Cardiovascular manifestations include a conduction defect that produces a characteristic prolongation of the QT interval in the electrocardiogram. Dental abnormalities occur when hypocalcemia is present during early development. These findings are highly characteristic of hypoparathyroidism and include dental hypoplasia, failure of eruption, defective enamel and root formation, and abraded carious teeth. Pseudo-hypoparathyroidism. In this condition, hypoparathyroidism occurs because of end organ resistance to the actions of PTH. Indeed, serum PTH levels are normal or elevated. In one form of pseudohypoparathyroidism, there is end organ resistance to TSH and FSH-LH, as well as PTH. All of these hormones signal via G protein coupled receptors, and the disorder results from genetic defects and components of this pathway that are shared across endocrine tissues. PTH resistance is the most obvious clinical manifestation. It presents as hypocalcemia, hyperphosphatemia, and elevated circulating PTH. TSH resistance is generally mild, while LH-FSH resistance manifests as hypergonadotropic hypogonadism in females. The endocrine pancreas. The endocrine pancreas consists of about 1 million clusters of cells, the islets of Langerhans, which contain 4 major and 2 minor cell types. The four main types are beta, alpha, delta, and PP pancreatic polypeptide cells. They can be differentiated by the ultrastructural characteristics of their granules and by their hormone content, figure 24.27. The beta cells produce insulin, which regulates glucose utilization in tissues and reduces blood glucose levels, as will be detailed in the discussion of diabetes. The alpha cells secrete glucagon, which stimulates glycogenolysis in the liver and thus increases blood sugar. The delta cells secrete somatostatin, which suppresses both insulin and glucagon release. The PP cells secrete pancreatic polypeptide, which exerts several gastrointestinal effects, such as stimulation of secretion of gastric and intestinal enzymes and inhibition of intestinal motility. These cells not only are present in islets, but also are scattered throughout the exocrine pancreas. There are also two rare cell types, D1 cells and enterochromaffin cells. D1 cells elaborate vasoactive intestinal polypeptide VIP, a hormone that induces glycogenolysis and hyperglycemia. It also stimulates gastrointestinal fluid secretion and causes secretory diarrhea. Enterochromaffin cells synthesize serotonin and are the source of pancreatic tumors that cause the carcinoid syndrome, Chapter 19. The following discussion focuses on the two main disorders of islet cells, diabetes mellitus and pancreatic endocrine tumors. Diabetes mellitus. Diabetes mellitus is a group of metabolic disorders sharing the common feature of hyperglycemia, caused by defects in insulin secretion, insulin action, or MOST. Chapter 24. The endocrine system. A B cells, insulin BA cells, glucagon CD cells, somatostatin, DE figure 24.2. 7 hormone production in pancreatic islet cells. Immunoperoxidase staining shows insulin in beta cells A, glucagon in alpha cells B, and somatostatin in delta cells C. D. Electron micrograph of a beta cell shows the characteristic membrane-bound granules, each containing a dense, often rectangular core and distinct halo. Portions of an cell left and a delta cell right also show granules but with closely apportioned membranes. The cell granule shows a dense, round center. Electron micrographs courtesy Dr. Arthur Like, University of Massachusetts Medical School, Worcester, Mass. Commonly, both. The chronic hyperglycemia and attendant metabolic deregulation may be associated with secondary damage in multiple organ systems, especially the kidneys, eyes, nerves, and blood vessels. In the United States, diabetes is the leading cause of end-stage renal disease, adult-onset blindness, and non-traumatic lower extremity amputations. Diabetes and related disorders of glucose metabolism are common. According to the American Diabetes Association, diabetes affects more than 30 million children and adults, or more than 9% of the population, in the United States, of which about 1.2 million have the form of diabetes called type 1, and the remainder have type 2. Astonishingly, nearly 1/4 of these individuals are currently unaware that they have hyperglycemia. Approximately 1.5 million new cases of adult diabetes are diagnosed each year in the United States. Furthermore, a staggering 84 million adults in this country have impaired glucose tolerance or prediabetes, which is defined as elevated blood sugar that does not reach the criterion used for an outright diagnosis of type 2 diabetes, T2D, see later, and individuals with prediabetes are at risk for developing frank T2D. Compared to non-Hispanic Caucasians, Native Americans, African Americans, and Hispanics are 1.5 to 2 times more likely to develop diabetes in their lifetimes. The World Health Organization estimates that as many as 422 million people suffer from diabetes worldwide, with India and China being the largest contributors to the world's diabetic burden. Increasingly sedentary lifestyles and poor eating habits have contributed to the simultaneous escalation of T2D and obesity, which some have called the diabesity epidemic. Sadly, this epidemic has now spread to children living in food deserts, who subsist on highly processed foods rich in carbohydrates and sugar, and do not exercise adequately. The mortality rate from diabetes varies across countries, with middle and low-income nations accounting for almost 80% of diabetes-related deaths, and nearly double the mortality rates observed in high-income nations. Nonetheless, diabetes remains in the top 10 killers in the United States. The total yearly cost related to diabetes in the United States is estimated to be an astounding $327 billion, including $237 billion in direct medical costs and $90 billion in indirect costs stemming from the reduced productivity of individuals with diabetes. Diagnosis blood glucose is normally maintained in a very narrow range of 70 to 120 milligrams DL. According to the ADA and WHO, diagnostic criteria for diabetes include the following. 1. A fasting plasma glucose greater than or equal to 126 milligrams DL. 2. A random plasma glucose greater than or equal to 200 milligrams DL in a patient with classic hyperglycemic signs, as the endocrine pancreas, 1099. A 2-hour plasma glucose greater than or equal to 200 milligrams DL during an oral glucose tolerance test, OGTT, with a loading dose of 75 grams. 4. A glycated hemoglobin HbA1c level greater than or equal to 6.5%. Glycated hemoglobin is further discussed later in the chapter. All tests, except the random blood glucose test in a patient with classic hyperglycemic signs, need to be repeated and confirmed on a separate day. If there is discordance between two assays, e.g. fasting glucose and HbA1c level, the result with the greatest degree of abnormality is considered the readout. Of note, many acute stresses, such as severe infections, burns, or trauma, can lead to transient hyperglycemia due to secretion of hormones such as catecholamines and cortisol that oppose the action of insulin. The diagnosis of diabetes requires persistence of hyperglycemia following resolution of the acute illness. Prediabetes, a state of dysglycemia that often precedes development of frank T2D, is defined by one or more of the following. 1. A fasting plasma glucose between 100 and 125 milligrams DL, impaired fasting glucose. 2. A 2-hour plasma glucose between 140 and 199 milligrams DL, following a 75G oral glucose tolerance test, OGTT, impaired glucose tolerance. And, or 3. A glycated hemoglobin, HbA1c level between 5.7% and 6.4%. As many as 1/4 of individuals with impaired glucose tolerance will develop overt diabetes over 5 years, with additional factors such as obesity and family history compounding the risk. In addition, individuals with prediabetes also are at significant risk for cardiovascular complications. Classification. Although all forms of diabetes have hyperglycemia as a common feature, the underlying abnormalities involved in its development vary widely. The previous classification schemes of diabetes were based on clinical features, such as the age of onset of disease and the mode of therapy. In contrast, the current classification reflects our greater understanding of the pathogenesis of each variant, Table 24.6. The vast majority of cases of diabetes fall into one of two broad classes. Type 1 diabetes, tone D, is an autoimmune disease characterized by pancreatic beta cell destruction and an absolute deficiency of insulin. It accounts for approximately 5% to 10% of diabetes, and is the most common subtype diagnosed in patients younger than 20 years of age. Type 2 diabetes, T2D, is caused by a combination of peripheral resistance to insulin action and a secretory response by pancreatic beta cells that is inadequate to overcome insulin resistance, relative insulin deficiency. Approximately 90% to 95% of diabetes patients have T2D, and the vast majority of such individuals are overweight. Although classically considered adult onset, the prevalence of T2D in children and adolescents has been increasing at an alarming pace due to the increasing rates of obesity in children and young adults, particularly in Hispanic, Native American, and Asian ethnic groups. Classification of diaceteb. 1 diabetes, beta cell destruction, usually leading to absolute insulin deficiency. Immune-mediated idiopathic autoantibody negative. Type 2 diabetes, combination of insulin resistance and beta cell dysfunction. Other types, genetic defects of beta cell function, maturity onset diabetes of the young MODY, caused by mutations in
nuclear factor tera chen amodinine glucanase GK modido hepatiti nuclear factor inaptian
MODY 3, pancreatic and duodenal homeobox 1, PDX1 MODY 4 hepatocyte nuclear factor 1, HNF1B MODY 5, neurogenic differentiation factor 1, NURAD1 MODY 6, neonatal diabetes, activating mutations in KCNJ11 and ABCC8. Encoding KIR 6.2 and SIR1 respectively. Maternally inherited diabetes and deafness mid due to mitochondrial DNA mutations, M3243AG defects in proinsulin conversion insulin gene mutations. Genetic defects in insulin action, type A insulin resistance, lipoatrophic diabetes, exocrine pancreatic defects, pancreatogenic, or type 3 Celsius's diabetes, chronic pancreatitis, pancreatectomy, trauma, pancreatic cancer, cystic fibrosis, hemochromatosis, fibrocalculus, pancreatopathy. Endocrinopathies, acromegaly, Cushing syndrome, hyperthyroidism, pheochromocytoma, glucagonoma, infections, cytomegalovirus, Coxsackie B virus, congenital rubella. Drugs, glucocorticoids, thyroid hormone, interferon alpha protease inhibitors, beta-adrenergic agonists, thiazides, nicotinic acid, phenytoin, dilantin, Vaker. Genetic syndromes associated with diabetes. Down syndrome, Klinefelter syndrome, Turner syndrome, Prader-Willi syndrome, gestational diabetes mellitus modified. From American Diabetes Association, Diagnosis and Classification Net T. Abdil, EUFO, LTs, I2, L4, MS6 T-BAID. TBIS Care 37 Supple 1, 81s 90, 2014. Type 1100, Chapter 24, The Endocrine System. Table 24. Cause diabetes, imperative features of type 1 diabetes, clinical onset, usually childhood and adolescence. Type 2 diabetes, onset, usually adult, increasing, incidence in childhood and adolescence. Vast majority are obese, normal weight or weight loss, preceding diagnosis. Progressive decrease in insulin levels. Increased blood insulin early, normal or moderate decrease in insulin late. Circulating islet autoantibodies, no islet autoantibodies. Anti-insulin, anti-GAD, anti-ICA 512. Diabetic ketoacidosis in absence of insulin therapy. Genetics, major linkage to MHC class II genes, also linked to polymorphisms in CTLA4 and PTPN22, and insulin gene VNTRs. Pathogenesis, dysfunction in T cell selection and regulation, leading to breakdown in self-tolerance to islet autoantigens. Pathology, insulitis, inflammatory infiltrate of T cells and macrophages, beta cell depletion, islet atrophy. HLA, human leukocyte antigen, MHC, major histocompatibility complex, VNTRs, variable number of tandem repeats. Non-ketotic hyperosmolar coma more common. No HLA linkage, linkage to candidate diabetogenic and obesity-related genes, e.g. TCF7L2, PARG, FTO, insulin resistance in peripheral tissues, failure of compensation by beta cells. No insulitis, amyloid deposition in islets, mild beta cell depletion. The important similarities and differences between T1D and T2D are summarized in Table 24.7. A variety of monogenic and secondary causes are responsible for the remaining cases discussed later. Before discussing the pathogenesis of the two major types, we will first briefly review normal insulin secretion and the mechanism of insulin action, since these are critical to understanding the pathogenesis of diabetes. Glucose homeostasis. Glucose homeostasis is tightly regulated by three interrelated processes: glucose production in the liver, glucose uptake, and utilization by peripheral tissues, chiefly skeletal muscle, and actions of insulin and counter-regulatory hormones, including glucagon, on glucose uptake and metabolism. Insulin and glucagon have opposing effects on glucose homeostasis. During fasting states, low insulin and high glucagon levels facilitate hepatic gluconeogenesis and glycogenolysis, glycogen breakdown, while decreasing glycogen synthesis, thereby preventing hypoglycemia. Thus, fasting plasma glucose levels are determined primarily by hepatic glucose output. Following a meal, insulin levels rise and glucagon levels fall in response to the large glucose load. Insulin promotes glucose uptake and utilization in tissues discussed later. The skeletal muscle is the major 1 and type 7E2 sulfonylurea receptor K+ channel.